let's go ahead and get started with this. We are already a little bit late, and there are a lot of topics to cover. So as Femila introduced, I'll be talking to you today about the updates in the diagnostic pathology of genitourinary malignancies. So these updates happened, most of them happened between the 3rd and the 4th editions of the WHO Blue Book, as you know, and some of those updates are more current updates that happened between then, which was 2016, and then now. And I'll also be talking about some of the challenges that are associated with making diagnoses of these updates. So I'm going to talk mostly about the morphology of these tumors, just the morphologic aspects that are helpful to us in our day-to-day practice. Right. I will not be going in depth into any molecular aspects, and I will deal a little bit about immunohistochemistry, but it's going to be mostly a visual presentation. You will see that, and this is how I learn best, and I hope it will help you as well. Right. So this is where I work. This is this whole campus is the University of Minnesota, and our hospital is basically located inside the campus, and as you can see, it's right on the river bank over here. And this one happens to be one of the largest rivers in North America, or it is the largest river in North America. Some of you may know this is the Mississippi River. All right, so I'm going to mainly talk on these 4 major organ systems. I will, as you can see, I'm not covering penile carcinomas today because of time constraints. And on these 4 topics, I'll be dealing with some new or updated entities, which, as I mentioned earlier, most of these updates happen in the period between the 3rd edition of the WHO Blue Book and the 4th edition of the WHO Blue Book. And then, in addition, I will also be talking about staging updates in these carcinomas. And these staging updates, as most of you know, happen mostly between the publication of the 7th edition of the AJCC Cancer Staging Manual and the 8th edition of the AJCC. So let's go ahead and get started with updates in bladder pathology first. Right, so as an outline, as I mentioned earlier, we have some new and updated entities. So the new entities in bladder pathology, some of you may have used these terminologies before. So this is UPOMP, or urothelial proliferation of undetermined or unknown malignant potential. And then we have this newly described entity, that's the large nested variant of urothelial carcinoma. And finally, there are some updates and recommendations on how to diagnose the micropapillary variant best. And then, as I said, we'll also be talking about staging updates of these. The most controversial and the most important staging update is in the T1 substaging of bladder carcinoma. So what is this UPOMP? In the earlier edition, we had this entity called urothelial hyperplasia. Now, if you see, the urothelial hyperplasia entity has been completely removed, and instead it's been replaced by our UPOMP, the urothelial proliferation of uncertain malignant potential. So what is this UPOMP, and how do we diagnose this? So essentially, to start off, you need multiple thickened urothelium, which should not have papillary formation. And then you should not see any architectural disorder. If at all there is architectural disorder, it will only be minimal, and the same applies for cytological atypia too. There should only be minimal cytologic atypia. So let's look at an example over here. Okay, so on the lower right corner of the screen, here you can see pretty much normal urothelium. This is the normal thickness of the urothelium. In contrast, on this biopsy fragment, the larger fragment, you can see there is a marked thickening of the urothelium. So it's about, if you compare to this, it's about 3 to 4 times thicker than the normal urothelium. And in this low power, low magnification, you can also see that there's not too much of cytological atypia. There appears to be sort of monotony to all these cells. And also architecturally, the polarity is nicely oriented perpendicular to the basement membrane. Okay, so if you take a closer look, excuse me, you will again appreciate the contrast between the thickness of this proliferation versus the normal urothelium. And then you can see there is hardly any cytologic atypia. Most of these nuclei are nicely rounded. There are not any prominent nucleoli, and the chromatin is very fine and well behaved. Right? And you also do not see any mitotic activity or apoptotic debris. If at all there is any hyperchromasia, you find it in a rare cell. Okay. And then you also can see some other examples, some variations of this theme. In this example, this proliferation has most of the same features, but in addition, you also have a little bit of undulation here, and a little bit of shallow tenting and a little bit of deeper tenting over here. Again, if you look at this in higher magnification, you see most of the features that you saw in the earlier example, right? So there's not much of an architectural disorder. The cytology appears quite bland, and then you don't have any mitotic or apoptotic. So that is the definition of UPOMP. And most of these cases, most of these patients actually have a history of prior papillary urothelial carcinoma, which is low grade. This history is very common. And many of these, or most of these, are actually thought to represent either nascent low-grade papillary urothelial carcinoma or a shoulder lesion of a pre-existing or a pre-existent papillary urothelial carcinoma. So what do we mean by this? So if you see this example here, on the left side, there is clearly a proliferation, which is quite remarkable, and you see this low-grade fused papillary structure. So this would be an example of low-grade papillary urothelial carcinoma. And if you look on the right side over here, you can see this sort of pattern proliferation that seems to be an extension of this proliferation, but does not have all the features that we saw here. So if you look closer at this, you will notice that it fulfills all of the criteria that we were talking about just a little while ago of this UPOMP entity, urothelial proliferation of unknown malignant or uncertain malignant potential. So if you get this in isolation, that's the diagnosis you will make. And now you exactly see what I mean by a shoulder lesion. This is in the shoulder to this carcinoma. And then here's another example. This one is from the renal pelvis. So you can see a clear-cut papillary low-grade neoplasm over here, nice finger-like fronds lined by this neoplastic epithelium. And then if you come towards the right side, a little bit away from this carcinoma, you see this tented proliferation. It doesn't really form well-recognizable papillations. It's just like it's pulled up a little bit. And then compared to the normal urothelium here, you notice that the thickness is increased, but there is only very bland cytology. So this again would be an example of UPOMP if you get this in isolation. So whenever there is something like a diagnosis where you have uncertain or where you have something like a malignant potential, now the risk is, or the temptation is to use this as a wastebasket category, right? So that is what we should not be doing. So I want to show some examples of when we should not be using this terminology of UPOMP. So number one is when you have evidence that actually favors a low-grade carcinoma, okay? So what do we mean by this? So this proliferation, again, is flattened, again, is clearly thickened, and it looks like what we saw earlier, but I will show you some subtle differences that makes you want to call this actually a incipient low-grade carcinoma rather than a UPOMP. So architecturally, I can tell you that there is a subtle loss of polarity here. It's not a lot, but you can clearly see the disorder in the cell proliferation. And then if you go closer, you will also see multiple other features. So what are these features? So you see this nuclear hyperchromasia. It's not just present in one rare or isolated or even scattered cell. It's present in many cells in this proliferation. So hyperchromasia, hyperchromasia, hyperchromasia. So it's present everywhere, right? That's one feature. And then you also clearly notice this apoptotic debris. So that is a sign of proliferation. And then additionally, you also see there is a mitotic figure that's kind of away from the basement membrane. So all these features do not fit into the diagnosis of UPUMP, and this case is best diagnosed as a incipient low-grade urothelial carcinoma that's not yet formed its papillations. Okay, so let's look at another example here. So in this example, again, you see a flattened proliferation, clearly thickened urothelium. The polarity is nicely maintained. There is not too much of atypia. There is monotony, but there is something odd going on right here. You see there is a capillary, the presence of capillaries inside the urothelium, right? Not only that, there seems to be a sort of fibrovascular core inside the urothelial lining itself, right? So if you make deeper sections in this particular case, you will see this happen. So in the deeper sections, this actually clearly shows that there is a finger-like projection, fibrovascular core, your typical papillary formation. So you're not supposed to see this in a UPUMP. So this case is, again, best diagnosed as the early low-grade papillary urothelial carcinoma and not as a UPUMP. That's one. And then when you have evidence that actually favors a reactive proliferation and not a neoplastic proliferation. So what do we mean by this? So this is an example where you can see that the urothelium, again, is clearly proliferative. It's thickened, right? And if you take a closer look at this particular proliferation, the most striking feature, aside from the atypia of these cells, there is nucleomegaly, but it's all monotonous. You might see some rare mitotic figures in the basal layer. But of course, the most striking feature here is the abundance of inflammation. You see inflammation not only in the lamina propria, which has both acute and chronic inflammation, but inside the epithelium itself. So there are these numerous neutrophils, and there is also this metaplasia, if you observe carefully, metaplasia that's actually showing some mucin. So some mucinous metaplasia is also going on. All these are features of a reactive proliferation. So this is not a situation where you pump. And finally, you have atypical urothelium that just falls short of CIS. So this is a challenging topic to understand and diagnose. So I'll show several examples of what to do in these situations. But this is not a situation where you should be using UPUMP. UPUMP is essentially a diagnosis in the low-grade setting and not in the setting where high grade comes into the differential diagnosis. So this is typically anything that falls short of CIS is what is called as a urothelial dysplasia. Again, this is the high-grade dysplasia that we are talking about. So what do I mean by this? This is a really great example. So we have in the bottom where you can clearly see carcinoma in situ, which is flat urothelial carcinoma, and there is clear-cut anaplasia of these cells. So no problem in making a diagnosis of CIS. Right? And then on the left side, we see absolutely normal-looking urothelium. Now, on the right side, though, it doesn't look normal, and it hasn't acquired the features of CIS either. So this would be what we call as dysplasia. And you know this is not low grade because there is so much nuclear anisocytosis here and loss of polarity that this wouldn't fall inside the low grade spectrum. So this is dysplasia. However, it's not that easy. Dysplasia is a very challenging diagnosis to make in urothelium, and I will illustrate that with this particular example here. So here again, you see a section of urothelium with a lot of inflammation in the lamina propria. Okay? And let's kind of zoom in into this middle section over here. So you will see that this cellular layer obviously is not thickened, but then you have enlargement of the nuclei, you have coarse chromatin, and you also have overlapping of the nuclei. So that kind of looks suspicious for dysplasia. It's not really like slam dunk CIS, but it looks suspicious for it. However, you also find, we already saw a lot of inflammation in the lamina propria, but you also see the neutrophilic infiltration into the epithelium itself. So could all this just be reactive change? So this is a situation in which the diagnosis is very difficult to make, and this is a situation in which the term atypia, urothelial atypia, should be used, something that falls short of dysplasia or CIS. That's where we use urothelial atypia. So the next question should be, like, are immunostains actually helpful in differentiating the possibility of a reactive change from dysplasia, which is just before CIS, or CIS itself? So there have been a lot of studies, and we've used these immunostains for a long period of time, but the fact that we are still talking about this means that it's not entirely helpful, right? So let's take a look at an example here. So the proliferation on the right over here is clearly CIS, extreme degree of atypia, mitotic figures, and you also get a lot of architectural disorder. On the left, this one, even though it's thickened and it has mitotic figures in it, there is a sense of monotony, and you see all these irregular nuclear membranes. So this would be a reactive proliferation, right? So let's apply our immunohistochemical stains over here. So P53. So P53 is one of the first mutations to happen in high-grade urothelial carcinoma. And in CIS, as you see over here, this is a mutated pattern when all the cells stain positive. And then this is a wild-type pattern where you see some of the cells having this weak and equivocal staining pattern. So that coincides with reactive. So that's perfect. And then our next stain would be CD44. And we know that in reactive proliferation, CD44 is supposed to stain the full thickness of the urothelium. And that's exactly what it's doing in this case. Whereas in contrast, in CIS, you would see either no staining of CD44 or only a basal layer staining, right? And that's exactly what's happening here. So that's good too. And finally, our other marker is going to be CK20, right? And in reactive proliferation, we get CK20 staining only on the superficial or the umbrella cell layer. And that's exactly what's happening here. Whereas in contrast, CIS, you will get a full thickness epithelium. So this is the ideal scenario, and the stains work as you expect it to work, but this is a case where you can easily make a diagnosis by morphology alone. So let's take a look at another case. So in this case, again, you see clear-cut CIS in the top, high degree of anaplasia, and there is also some invasive carcinoma here into the stroma, right? So what does CK20 show over here? So we expect CK20 to be full thickness positive in CIS. But instead, in this case, you can see there's hardly any or no staining for CK20. So that's negative. And what about CD44? So it's quite unexpected. So here, you would expect CD44 to be negative in a carcinoma in situ situation. But in this case, not only is the carcinoma in situ staining so strongly, even the invasive component is staining. And then finally, P53 is not staining at all. So this is a CIS, an invasive carcinoma that is occurring through a molecularly different mechanism that does not follow the pattern of a traditional luminal type CIS, right? So it will be a problem when you're faced with such cases when the CIS is not so blatant. So what about something that's in between? So it is in this situation where we actually want the stains to help, right? So here you see clear-cut atypia. So there is architectural disorder, there is hyperchromasia, there are probably even a lot of mitotic figures in this epithelium, but you also see plenty of neutrophils infiltrating this epithelium, right? And they're even forming these microabscesses. So this could very well be a reactive proliferation, but we just want to make sure, right? So then we use our stains. So here's CK20. So you can see in most of the epithelium, it's staining only the top layer or the superficial umbrella cell layer, but there are areas in which it's also staining not only the middle layer, but also the bottom layer. And you can see the same phenomenon over here as well. So maybe this is carcinoma, but what about CD44? Here you see CD44, which is doing pretty much the same thing as CK20 or even more. So you expect CD44 in a malignant proliferation to be staining only the basal aspect or to be negative. But instead, in this case, it is almost showing a full thickness reactivity just like CK20. So what do you do in this situation? The stain's not helping, right? So the final conclusion that I would like to offer to this question is that, yes, it does help in some cases, but morphologic correlation is going to be key over here instead of completely relying on these immunostains. And when you do get these equivocal cases, which you will, then it is preferable to use urothelial atypia. You can even qualify the urothelial atypia as mild or moderate, severe, but falling short of CIS in the comment and or in the note, and leave it like that. Right. So let's move on to the next new entity, which is the large nested variant. So this is actually a subtype of the nested variant, and this variant all of you recognize very well. So the large nested variant was first described by Dr. Epstein and colleague, where they actually remarked that these mimic one-run nests like the nested variant, but they also can mimic an inverted growth pattern of a low-grade non-invasive urothelial carcinoma. Okay? So let's first take a brief look at the nested variant and what it actually means. So as you know, this basically is urothelial carcinoma that is made up of small nests that invade into the muscle, but they have very bland cytology. Okay? And here's an example. So you see a very regular proliferation of these urothelial nests, these small nests. And if you look closer, you will see that there's hardly any cytologic atypia. Right? They're rounded nuclear membranes. I can't really see much of the nucleoli, and the chromatin is also very regular. I don't see any mitotic figure. So classic description of nested variant of carcinoma. But we all know that this one is an aggressive tumor and it exhibits deep invasion. So here's the contrast between a nested variant of urothelial carcinoma and one-run nest. So actually, it's difficult to say which is what. In fact, if you look at this, this is an example of Brunn's nest, and the atypia in this one seems to be more than what we see in the atypia of the nested variant. So the key is to look deeper and zoom out, right? So when we do that, in the one-run nest, you will see, despite the fact that it's so florid, it's confined to, at the most, deep lamina propria, and it never should reach the muscle layer, or it never should go into the muscle layer. In contrast, if you look at the nested variant, so it not only penetrates the full thickness of the lamina propria, but it also clearly goes into the detrusor muscles or the muscularis propria. Okay. Now, one point as an aside, I just want to mention that it's critical that we do not make a diagnosis of a nested variant diagnosis on a biopsy from either the ureter or the renal pelvis, essentially the upper tract. Do not make a diagnosis of nested variant on the upper tract. The reason being, in the upper tract, the Brunn's nest proliferation can be very, very florid. So here's a great example of that. I'm sorry about the out of focus picture. So you can see lining of the renal pelvis over here, and this entire proliferation, which again is confined to just the lamina propria, is one Brunn's nest. So you can see how florid it is and how easy it is to make a diagnosis of nested variant when you get a biopsy from just this portion. And here's an example. This one is actually from the ureter. So here it gets a little bit more difficult because this was a stented ureter, and a stented ureter, often you can get edema in the lamina propria. And if you see the Brunn's nest within the edema, they get distorted and they actually look like invasive cancer. So one has to be very careful in this setting, making a biopsy diagnosis of nested variant of urothelial carcinoma. In fact, I never do that. Okay. So let's come finally to this large nested variant and see what it looks like. So essentially the concept is very simple. So instead of small nests, you basically have large nests with bland cytology. So here's a great example of a large nested variant. So you get these really large nests that are clearly invading the muscularis propria, right, in all directions. And then if you look closely, you will see most of them have a very bland cytology with very little atypia. In fact, these tumors, despite the bland cytology, often tend to present in a high stage. In this case, you can see there is a vessel in the perivesical adipose tissue that's being invaded by this large nested variant of urothelial carcinoma, again with bland cytology. So it can mimic the inverted pattern of low-grade urothelial carcinoma, right? Especially in a TURBT, transurethral resection of bladder tumor, which is so haphazard and unoriented, right? It might become a difficult diagnosis. But then again, we look for areas that show deep invasion. So here's an example. So you can see that this is a TA carcinoma. This is a low-grade urothelial carcinoma with an inverted growth pattern. But despite its growth pattern, you can see it's still confined to the lamina propria, and it never penetrates the muscular propria right here. In contrast, you can see a large nested variant, which has very comparable cytology and also architecture, but you can see clearly that the muscular propria, the large muscle bundles, are being invaded. So it is key to identify this feature, especially in tangentially cut biopsy specimens, where it's difficult to say whether this is an inverted pattern or whether this is a large nested variant. And this diagnosis is particularly important because the large nested variant, as I said before, despite its very bland cytology, it's a very aggressive carcinoma. All right. So let's move on to this micropapillary variant. So all of us have made the diagnosis of micropapillary variant several times now, but there are some nuances to it, and we'll look at those nuances. So the problem with the micropapillary variant is that it has very poor inter-observer reproducibility. I would say even intra-observer reproducibility, but it has very high clinical significance, right? Because many urologic surgeons, even if you say it's only a T1 disease with micropapillary variant, they will still go for radical cystectomy. It can be very dangerous. So the clarification of a diagnostic criteria for what should be classic micropapillary variant is very essential. So that's exactly what these authors did in this pretty large study. And they showed that the most reproducible diagnostic criterion is the presence of multiple micropapillae in the same lacunar space. What do we mean by this? So you see, here is a great example. So you can see one lacunar space, one complete space, and within the space, you get multiple small nests of micropapillae. So these finger-like projections without fibrovascular coils are called micropapillae, and you can see many of them in a single lacunar space. So this is when we should be calling something as a micropapillary urothelial carcinoma. And then they also found in that study there are some other features that are not as specific as the one I just showed, but still have very high specificity. So these are called the epithelial ring forms and intracytoplasmic vacuolation. So what is an epithelial ring form? So right in the center of this micropapillary cluster in a lacunar space, you can see the epithelial ring form. Essentially, it looks like a small or poorly formed gland with a central cystic space surrounded by these epithelial cells. This is called an epithelial ring form. And then you can also see intracytoplasmic vacuolation that essentially look like signet ring cells, right? So these are the features that are also highly specific for the diagnosis of micropapillary variant. And then, as we saw with the U-pump, we also should know when not to pull the trigger on micropapillary carcinoma, because obviously we have very severe clinical implications when we make this diagnosis, right? So when you see large or medium-sized anastomosing nests with some retraction space, or many times you also might see small individual cells that have a retraction space with them. So let's look at some of the examples. What I actually mean by this. So here you can see some large nests of urothelial carcinoma, which are kind of anastomosing, but also have this retraction space around them. So here maybe nobody's going to call this micropapillary or anything like that. But when you get a different morphology like this, where you get both the large nest, also some medium-sized nests, and with retraction space, it becomes very tempting to call this as a micropapillary urothelial carcinoma. Right, and another situation you may face is when you get these micropapillary or finger-like structures, but only one of them or a small cluster in a retraction space by itself, right? So this is also not a situation where we should pull the trigger on micropapillary carcinoma, because this phenomenon happens in very many cancers, as we know. So the only situation in which you can confidently call something micropapillary is this. All right, and then the other thing to remember is the fact that there are some cases where you might see micropapillary formation only as an in situ or non-invasive component, right? And here are a couple of nice examples. So you can see all these clusters of urothelial carcinoma that are clearly forming these micropapillary structures, but there is actually no stroma at all. These are essentially detached clusters. In this situation, and also in this particular situation, where you can actually see the surface urothelium, and from the surface urothelium, you see this in situ component of high-grade carcinoma that's actually growing as micropapillary structures, right? So no invasive again. So in both these situations, studies have shown that this does not have the same prognostic impact as invasive micropapillary carcinoma, and one should not use that terminology in. All right, so let's move on to some staging updates. And T1 staging is actually somewhat challenging. There are so many studies going on in this arena now, and we'll probably hear something soon in the next edition of the WHO manual, which is coming out later this year. So why is this important? So we all know that the depth of lamina propria invasion is both pathologically as well as prognostically heterogeneous. So what do I mean by that? So here are a couple of examples. So here you see a surface proliferation of urothelium that is clearly a carcinoma, papillary urothelial carcinoma, but you also see invasion in the superficial lamina propria below in multiple foci, right? And this is another example where there is a denuding cystitis or a denuding CIS, and underneath that you see this invasive component, which is very focal. Okay? In contrast, there are a couple of other examples here. Right here, this entire fragment of a TURBT specimen is essentially involved by invasive carcinoma from top to bottom. I don't see any muscle here, so I will assume that this is all lamina propria invasion. And then finally, another example here from a cystectomy specimen, you find that the entire lamina propria is packed to the brim with invasive carcinoma, and it stops just short of the muscularis propria. Now, all these are technically T1 carcinoma, but you can clearly see why these two will behave completely different from these two. These are clearly much more aggressive looking carcinomas, and there should be a way in which we have to designate this correctly, right? So diagnostic substratification of T1 urothelial carcinoma is very essential. Now, the problem is, on like why this has not been done so far is the fact that anatomical substaging, which is typically done in all other organ systems, is very difficult in the bladder. This is because the lamina propria as a structure is histologically very inconsistent and variable in the bladder. So what do I mean by this? So here you can see a full thickness section of the bladder, right? With the urothelium on top. This is the luminal space. And if you try to designate the lamina propria here, this is what you get. So you can clearly see the variable thickness in the lamina propria here. So here's very thick and it's very thin, and there are several areas with intervening thickness. So it's a very ill-defined area. Not only that, some of the major anatomical landmarks that we use in the lamina propria, the most important one would be, of course, the muscularis mucosa, which we see over here. These very flimsy bundles of smooth muscle that we find in the lamina propria. So you can see that these are not only flimsy, but disjointed. In fact, they are so disjointed that in some areas they're entirely absent, and then it continues elsewhere. So using this as a landmark in all biopsies also becomes very difficult because in some cases they may not be present at all, right? So that's why multiple systems have been studied, which includes these histologic landmarks. And then people have also extensively studied measuring the size of the tumor and trying to determine prognosis from that. In fact, this probably will be the most adoptable strategy for substaging PT1 into either greater than 1 millimeter or less than 1 millimeter tumor. And finally, people have also studied depth of invasion. However, because of various issues, there are no consensus guidelines yet. But it is important to understand, because of the heterogeneity in prognosis, we have to indicate some form of qualification to the lamina propria invasion. So the way I do it is like this. So here you can see an example of the lamina propria, this urothelium on top, and then you find muscularis propria in the bottom, and in between is first the lamina propria. And I have pointed out the bundles of muscularis mucosa bundles over here. And then there is also another anatomical structure which could be useful in the setting, which is the thick-walled blood vessels, which you typically find somewhat in a loose association with the muscularis mucosa bundles. So you kind of draw an artificial line which separates layer above these two structures, which would be superficial lamina propria, and a layer below the structure, which would be deep lamina propria. So using this, you should say at least whether there is a superficial or a deep invasion, or if the T1 invasion is either focal or multifocal, or if it is extensive, right? So let's take a look at some examples on how this diagnosis can be made. So in this particular case, again, I showed this before, it would obviously be a superficial focal T1 in the diagnosis, high-grade urothelial, invasive high-grade urothelial carcinoma with superficial focal lamina propria invasion. In contrast, in this case, there's no point in just saying lamina propria invasion is present, right? So we have to say that there is very deep and very extensive lamina propria invasion. So most of our surgeons, when they hear this, they will treat this patient as if they have muscularis propria. All right, finally, I want to talk briefly about some changes or some clarifications involved in the staging of urothelial carcinoma that involves the prostate gland, okay? So in the previous edition of the AJCC manual, it simply stated that PT4 stage is assigned when the urothelial carcinoma involves the prostatic stroma without any further qualification. So this was further clarified in the new edition where it says the tumor directly invades the prostatic stroma. So what does this mean? So here you see an example of a urothelial carcinoma. That's the coronal section of the bladder and prostate, which starts in the bladder and then penetrates through the wall of the bladder neck and then goes into the prostatic stroma. So essentially, in real life, it would be like this, and you see a prostatic stroma here, and it has to extend all the way like that. The other way in which urothelial carcinoma can invade the prostate is like this, through the urethra itself. So you can see that the cancer is coming through the urinary sphincter between the bladder and prostate, and then involving the prostate from there. So essentially, it would be something like this through the urethra. So let's take a closer look at that. And here you can see carcinoma in situ, or urothelial carcinoma in situ, involving the prostatic urethra. And from the prostatic urethra, it basically flows down through the prostatic ducts, because the ducts essentially drain into the urethra, right? So you can see urothelial carcinoma into the prostatic ducts. And this is how it enters the prostate. So these two have to be staged entirely differently. So if you get direct invasion through the bladder wall, this is the situation in which PT4 or adjacent organ involvement invasion should be assigned. But if it extends through the prostatic urethra, this will not be a PT4. So it will be assigned various stages according to where the invasion is, or is, as in some cases you may not find any invasion at all. So when the cancer spreads through the urethra into the prostatic ducts and acini, it doesn't matter how extensive it is. Sometimes you might see the cancer just spreading as carcinoma into the ducts all the way up to the periphery of the prostate. This will still be PTIS. And in some cases, you can see this PTIS actually invading the prostatic stroma from the ducts. So in this case, again, it will not be PT4, it will only be a PT2. Let me show you a few examples here. So this is a urothelial carcinoma in the prostate, and you can see how extensively it's involving all the prostatic glands right here, and it's also involving the prostatic acini here. And believe it or not, all this is just in situ carcinoma. One, because most of it is rounded, it's involving the ducts. So if you don't believe it, I will show you an immunohistochemical stain. So CK56, I have found it's a very good stain in this situation, despite the fact that most of us know CK56 will stain both the the basal layer of the prostate as well as urothelial carcinoma, right? Despite that, it preferentially stains the basal layer of the prostate better than urothelial carcinoma. So in this example, you can see it's staining some of the inside the urothelial carcinoma, but it's also staining the basal layer of most of these glandular structures as well as the acini. So this is all confined to the glands and the acini, so that in situ carcinoma still would be PTIS for urothelial carcinoma. In this example, it's actually very jagged, and you can see even sort of a desmoplastic stromal reaction around it. It's very tempting to call this as invasive carcinoma into the prostatic stroma. However, it's good to remember that the prostatic acini normally have a very jagged contour like this, right? So if you do a CK56 stain here, you will see exactly that phenomenon. This invasiveness, this jaggedness that looks like it's invasive into the stroma is actually enveloped by this basal layer of cells. So this would still be a PTIS. So finally, this last example, here is where you get true invasion into the stroma. You see these two clusters and a few clusters here. In this case, if you do the stain, there are no basal cells at all. So this is invasive into the prostatic stroma, but remember, this is still not PT4. If it invades from the duct, it's still a PT2. So it's present throughout, right? Another example here where you can see this papillary urothelial carcinoma, which is involving the diverticular tract. But if you observe carefully, you can see a portion of muscularis mucosa, which is present in the lamina propria, is being dragged along with the diverticular tract to the deep muscle, right? In higher power, you can clearly see this. So this is superficial lamina propria, muscularis mucosa, deep lamina propria, so all the layers are still present. So we have to classify the invasion as it happens here and not just call it PT2. So let's look at some examples here. So this is urothelial carcinoma, a non-invasive papillary urothelial carcinoma, which is involving a deep diverticulum. This will, of course, be called a PTA. And if it's not papillary but flat, it's going to be called a PTIS. And then in this situation, this is where it's important to understand that when the carcinoma invades from a diverticulum, it can still be confined to just the lamina propria of the diverticulum and not go into the muscle. So this would still be as a PT1. So that brings me to the end of the bladder pathology session. I will continue with the kidney session before we take a break. So this is an image of downtown Minneapolis in the late summer. It's, some of you may or may not know, Minneapolis is actually called the land of 10,000 lakes. There are so many lakes over here, and this is actually one of the smaller lakes that's present right in the center of downtown Minneapolis.
Thank you,
sorry,
Dr.
I think
Paari.
I said kidney, but yeah, yes.
That was really a huge
Hello.
collection of. Can you hear me?
Yes, I can hear you. Go ahead, please.
Thank you, Dr. Paari. That was really a huge collection of challenging cases, which we generally do not get on pathology residents are greatly benefited.
Perfect. Thank you, Famila, and you're welcome. I could not hear you very well, but I think I got the gist of what. Let's go ahead and look at some updates on prostate pathology before we take a brief break. So the outline will be similar to what we had for bladder pathology. So I'll just talk a little bit about the new entities and updated entities, and then there is actually nothing that happened in the staging of prostate cancer. The only minor change, I'm not going to talk about it again, the only minor change is that the substaging for PT2, essentially what we used to do as PT2A, B, and C, depending on the extent of the prostate involved, has been removed. So there is only one stage, that is PT2, because none of the substaging had prognostic significance. That's about it for prostate staging updates. So let's look at some of the diagnostic updates in prostate cancer. The first one, as most of you already know and are already doing it in your practice, is that we have adopted the system called the grade group, which is slowly replacing the Gleason scoring system. So this is essentially a simplified system which gives a 5-tier grade group instead of this sort of cumbersome Gleason scoring system that has so many numbers over here, which is very confusing to patients and many clinicians. So in this simplified system, to illustrate how it is helpful, is that, like, for example, you see a patient with Gleason score 6, 3+3 carcinoma. We all know that that's a very indolent low-grade prostate cancer, right? But we would tell the patient and the urologist that you have 6 out of 10 cancer grade, right? So for a layperson, this would mean, okay, I have 6 out of 10, which means either it's moderate or it's worse than moderate cancer, which is not the case at all. This is the most indolent or low-grade prostate cancer we can see, right? So this grade group system actually makes for better understanding, because in this situation, you would just say grade group 1 out of 5, which everyone can understand is the lowest grade, right? So it is helpful in that way. And also another important way it helps is it substratifies the Gleason score 7 into grade group 2 and grade group 3, depending on which is the primary score. If the primary score is 4, then it becomes a grade group 3. So this is also very important, because most of the prognostic nomograms used to actually just say Gleason score 7 instead of substratifying into 3+4 or 4+3, which we know makes a lot of difference prognostically, right? So this grade group actually fixed that problem as well, because now all the nomograms either use grade group 2 or grade group 3. So that's important. And then the grade groups have also shown strong correlation with prostate cancer biochemical recurrence. So it really works. And this is what we are adopting right now. We still give Gleason score, and in the next line, we also say what grade group it belongs to. So, and then let's look at some updates in Gleason patterns themselves. The first update is very simple. We all know this very well. Gleason, when he designed the Gleason scoring system, had everything from Gleason pattern 1, Gleason pattern 5. But now we know that we don't ever use Gleason pattern 1 or Gleason pattern 2 because of the lack of reproducibility, especially in a biopsy setting. And we also know that Gleason pattern 1 and Gleason pattern 2 don't necessarily correlate with a more favorable cancer than Gleason pattern 3. So let's look at an example here. This is a biopsy in which you get a really well-demarcated proliferation of discrete glandular structures with lines lumina, right? And then you do your stains, you see that the high molecular weight keratin is negative for the basal layer, but the Amicar or P504S is diffusely positive, right? So this is a pattern in the past, because it is so well circumscribed and it's so low grade, tightly packed, acini, which are still discrete, would be called as a Gleason pattern 1 or Gleason pattern 2. Now we don't use this anymore. Even if we see this in a biopsy, we will still call it Gleason pattern 3+3 = 6 or grade group 1. And then the more important updates are in how to correctly diagnose Gleason pattern 4 itself, right? So there have been some contemporary changes in this, and most of this has happened in this category, the poorly formed fused glands. Some changes have also happened in how to correctly diagnose glomerular formation, and we all know how to diagnose cribriform proliferation of Gleason pattern 4. Right. So this is very important to correctly diagnose Gleason pattern 4 because the contemporary Gleason pattern 3 cancer does not metastasize at all. So if you correctly diagnose this, all these patients should ideally just go into active surveillance and nothing more should be done for them. So that's why it's important. So let's take a look at some of the examples of Gleason pattern 4 here, the contemporary grading of pattern 4. So here is a case where the lower part of the biopsy right here shows discrete malignant glands separated by stroma with nice lumina. So this would be easily diagnosed as a Gleason pattern 3. But if we look at the upper part of the core, right? So here we see there is a lot more complexity happening in the glands. So let's take a closer look at this area. And then we can see most of the glands are kind of shrinking in size. They become smaller and smaller. They start losing their lumens, right? So these are called poorly formed glands. Not only that, they also start fusing with each other. So this combination is called the poorly formed fused pattern of Gleason 4. Okay. So here's an example of another pattern, Gleason 4. So most of these glands you can see are well developed and discrete glands with open lumina. But there are some areas, if you notice carefully, that clearly show these glomeruloid formations. Right, one is over here and the other is over the top, and you can see 2 or 3 glands with the glomeruloid formation. So this would be Gleason pattern 4 carcinoma as well. In the past, this kind of glomeruloid formation, only if we see in larger glands, we used to diagnose as pattern 4, but now it doesn't matter. Even if the gland is very, very small and it shows a glomerular formation, still call it Gleason pattern 4. The caveat here is to be careful with what we call as glomerular formation because we have started calling even very small ones as Gleason pattern 4. So in this example, I would not call this a glomeruloid formation because many glands in Gleason pattern 3 are actually can be large and convoluted. Like for example, you see a malignant gland here which is large and convoluted. So when that is present and you get some sections, some of those can be tangentially cut. And you can have invaginations that go in which look like glomeruloid formations, but it is different. I will show you how. So here's another invagination which goes in and it's not glomeruloid Gleason pattern 4. Because if you look at this, look at the orientation of these nuclei. So all these nuclei are oriented towards the core of this invagination. And on the luminal side, you still see the clearing of cytoplasm and this columnar appearance, which is very similar to what you see in the other area of the gland. So you can imagine how this invaginated and took on the appearance of same appearance as of this. And the same is happening over here. All the nuclei are oriented towards the center of this invaginating cluster. And then on the sides, you see the cytoplasm. Which is very different from what you see over here in the real glomeruloid formation, where all the nuclei are so haphazardly arranged and you don't get the orientation that you see in the rest of the gland. Same here. So these would be Gleason pattern 4 and these would not be. And then finally, you have to make sure that you avoid calling tangential sections of Gleason pattern 3 as Gleason pattern 4. In my mind, this is one of the key confounders leading to Gleason pattern 4 overcall, right? So let's take a look at a couple of examples quickly. So here you can see discrete Gleason pattern 3 glands. And then in this area, if you look closer, you can see these small, poorly formed, and in many places, fused glands, clearly at least Gleason pattern 4, right? So in contrast, see another biopsy over here that shows discrete glands again. This is Gleason pattern 3. But if you look carefully, there are some glands in the background which are small and poorly formed. When you look closer at them, you will see that some of them even appear a little bit fused. But you can see the difference between this and this, right? So in prostate cancer, which is essentially a 3-dimensional structure that we are cutting. So let's say the cluster of Gleason pattern 3, the cut goes through either the top of the gland or the bottom of the gland. You will get tangential sections that look like poorly formed glands. So it's important not to overcall these as sort of this. It's important to keep this as Gleason pattern 3+3 grade group 1, whereas this would be grade group 2. Okay. And then the other change is that we have to include percentage of pattern 4 in grade group 2, where we get a 3+4 cancer diagnosis. So this is important because some patients who have 3+4 cancer may still be put on active surveillance if they have a low amount of pattern 4. Right. So here you see in this example again, we saw only very few glomerular formations. So this would be a very low amount of pattern 4. We would still call this 3+4 7, but we indicate to the surgeon that the pattern 4 is very less. So you might still want to consider active surveillance in this patient. In contrast, in a case like this, you want to tell the surgeon, imply to them that, you know, there is Gleason pattern 3, there is also 4. This will still be grade group 2, but there is a lot of 4 here. There's almost 40% pattern 4. So this patient may not be an ideal candidate for active surveillance. So it's important that we mention the percentage of pattern 4. Okay? And then some more updates on the Gleason pattern. So this cribriform pattern is one that we have not looked at so far. So here you can see a very easy diagnosis of Gleason pattern 4 because these are cribriform, back-to-back fused glands, right? But the studies have several times showed us that when you have metastasis in prostate cancer, it is this cribriform pattern that tends to metastasize. So obviously this has a poorer prognosis than other patterns of Gleason 4. So again, we have to indicate this to the surgeon and oncologist. And whenever we see this, it is not enough to simply call this 3+4. We have to say that cribriform pattern 4 is present so that they know this patient should not go into active surveillance. And then finally, we need to talk a little bit about tertiary patterns and biopsies. So it's important to remember that we never use tertiary pattern in a biopsy setting. It's only used in the setting of a radical prostatectomy. Right? So what if you get a less than 5% carcinoma or less than 5% of any pattern on a prostate biopsy? What should you do? So let's take this example. So here you see mostly Gleason pattern 4, either cribriform or fused glands. Maybe focally, you still see discrete well-formed glands. So essentially here, there is some Gleason pattern 3, but it's very minimal, less than 5%. So when you have a lower grade, which is less than 5%, you should ignore it. So this case, I would call as 4+4 equal to 8 and ignore this less than 5% pattern 3. In contrast, let's take this situation where you get a higher grade, this glomeruloid formation, which is still less than or equal to like 5%. So in this situation, you should not ignore this. In fact, you should take this as a secondary score and make this 3+4 equal to 7, grade group 2 instead of 3+3 equals 6. That's what it means by higher grade less than 5% should be included as a secondary pattern. So the final concept that we want to discuss in prostate, the updates would be this entity called intraductal carcinoma of the prostate. So this can occur in two ways, right? It can either be a manifestation of retrograde spread of very high-grade invasive carcinoma back into the ducts. Okay, so this is called as regular type. And then there's another type where it's called as a precursor-like type. So you can get a patient who develops high-grade PIN, and the high-grade PIN acquires mutations, and then it becomes a more higher-grade cancer, which we call as intraductal carcinoma. Or sometimes it can directly develop without going through this high-grade PIN stage. That's called the precursor-like type. So the bottom line is it's important to know that all types of intraductal carcinoma, or both these types of intraductal carcinoma, are typically associated with high-grade invasive carcinoma. So let's take a look at a couple of these. So here you can see very high-grade prostate cancer like Gleason pattern 4 and maybe a little bit of 5. And this duct in the center, you can see the basal layer is involved by retrograde spread of this cancer into the duct. So this is one type of intraductal carcinoma, which is in fact the most commonest type. And then in a prostatectomy specimen, you can see this phenomenon even better, where the invasive carcinoma is clearly invading into the pre-existing ductal structure. So this will be intraductal carcinoma of the regular type, right? In contrast, the precursor type is where you get a pre-existing duct, and then you start developing mutations that make it very high grade. So this would be a precursor type of intraductal carcinoma. And then, as I said, even this can be associated with adjacent high grade carcinoma. So clearly, when you see this, one obvious question is, how do you differentiate this from a regular high grade pin, right? So there are some criteria that we use to differentiate intraductal carcinoma, especially the precursor type, from high grade pin. One is you need to see severe nuclear atypia that is beyond what you would see in a high grade pin, or you should see a very complex cribriform proliferation that occupies like more than 50% of the ductal space, or the proliferation can sometimes even be close to solid, or you need to see comedonecrosis within the duct. Right, so you need to see one or more of these features to call something as a high-grade pin. So let's look at some examples here. This is a typical case of high-grade pin where you see stratification, nuclear atypia, and some arching and some bridging. Right, so this is a complex proliferation, which is high-grade pin. Yes, excuse me. Please notice that in this case, as you go towards the center of this duct, the nuclei actually become smaller and they become more matured. So this is typically what happens in high-grade pin, right? In contrast, in intraductal carcinoma, you can see that the nuclear atypia is much more marked, right? It's very anaplastic over here, and even if you go towards the center, it still maintains its high-grade characteristic and it doesn't shrink down like this. The other way you can diagnose intraductal carcinoma is when there is a very complex cribriform proliferation, as I mentioned earlier. In this case, this would be an intraductal carcinoma, or at least an atypical intraductal cribriform proliferation, which is higher than a high-grade pin. Or, as I said before, you need to see necrosis. So this comedo type of necrosis within the duct. You can see that's still within the duct because there is still this basal layer. This would be another type of. So why are we stressing so much on this intraductal carcinoma? Why is this even important? Because sometimes you get isolated presence of intraductal carcinoma in the biopsy. At these times, it's very important to indicate to the surgeon that they should go back and rebiopsy again, because most of these intraductal carcinomas are associated with adjacent or in other parts of the gland, very high-grade prostate cancer. So that's why intraductal carcinoma is important to diagnose. So with that, I think we can wrap up on the prostate, and this would end the first part of it. Any questions, please?
Thank you, Dr. Paari. So shall I read the queries from the audience now, or shall we break and then continue with the slide discussion?
It's up to you, depending on how your schedule will work. I'm fine.
Okay.
Either way.
The queries later, the audience may directly ask you when you discuss the cases. Now they have sent for the session some of the queries. Dr. Sandhya Sundaram, who is professor and head of the department of Sri Ramachandra Institute of Higher Education and Research, she has questioned, would any IHC help to differentiate one brand from nested variant in a TURBT or a biopsy, as it is a challenge?
Yeah, that's actually an excellent question. So I should say that IHC is not very useful in this setting. However, there have been some studies that have explored the value of PAX8 in this setting. Literature actually shows that the nested variant of urothelial carcinoma more often tends to be positive for PAX8 than the Bruns nest, right? Which you would not expect. You would not expect urothelial cells to be positive for PAX8 unless they are in the upper tract. But in the nested variant, it can be positive. I mean, not in all cases, but if you do it and it's positive, you can suspect a type. But other than that, there is nothing. There are some molecular studies. Many nested variants can have TERT mutations, which you do not find in Bruns, but that's kind of a very expensive thing to do, so usually people don't.
The attendees and we are complimenting excellent presentation, and Thank you so much for the nice and informative talk. The audience have commented so.
Let's go ahead and continue with updates in kidney pathology. So obviously, as we all know, the major update in kidney pathology has been the WHO and ISUP grading system. We have given up the Furman grading system, which we've been using for many years now, and now we are using this new grading system. And then there are several other new entities or updated entities that have come up, and we'll look at some of these in detail. And then finally, there is a minor staging update like we had in prostate carcinoma, but it's a little bit more complicated than prostate. So I will go briefly into this as well. So let's start with the WHO and ISUP or RCC grading system. So the Furman grading system, as we all have known for so many years, has been abandoned now, mainly because many of the cancers diagnosed with the Furman grading system have had variable outcomes, and they did not really correlate very well with the Furman grading system. And more than that, it had low reproducibility among pathologists. And there was also this issue of discrepancy between the grading parameters. So what do we mean by that? So we know the Furman system basically had many parameters, which included the nuclear size, the nuclear membrane irregularities, and then the prominence of the nucleoli. So in this particular example of clear cell renal carcinoma, we can see that the nuclei are enlarged in contrast to the RBCs around here, and there are also prominent nucleoli, but all the nuclear membranes, if you look at it, are very well rounded and very smooth, right? So it really doesn't, the size and the nucleolar prominence really doesn't match up with the nuclear membrane here. In contrast, here's another example. So here you can see the nuclear membrane is irregular, right? Clearly irregular, but in many of the cells, but you don't really see prominent nucleoli, and you can see that some of the nuclei are actually not very large. So here again, there is a discrepancy between the membrane irregularities versus the lack of nucleoli and enlargement in nuclear size. So in these cases, it was difficult to accurately grade these tumors. So this was one of the reasons why this study was done, to look for a better grading system for renal cell carcinomas. And it has been shown that the ISUP grading system has superior outcome correlation compared to the Furman grading system. And this is a very easy grading system to adopt. So it has a much better inter-observer reproducibility as well, because it is basically just based on the nucleolar prominence, because it was found out that among all the criteria in the Furman system, the nucleolar prominence is the one that really mattered, right? So we use this for grades 1 to 3, and grade 4 has remained the same. So this would be basically renal cell carcinomas that have either sarcomatoid morphology or rhabdoid morphology or extreme pleomorphism. So quickly, let's look through some examples of this grading system now. The ISUP WHO grading system goes like this. So we use grade 1 when the nucleoli are not visible, or even if they are visible, they are very small and basophilic, right? This is even at 40x, you cannot see them. So grade 2 is when you can see the nucleoli, but they are not very prominent at 10x. At 40x, they become prominent and eosinophilic, but at 10x, it will be like this. It will not be very prominent, but it's obviously different from what we see in grade 1. Grade 3, on the other hand, is when you have very prominent and macronucleoli that's easily visible even at 10x magnification. So that would be grade 3. And grade 4, either sarcomatoid or rhabdoid, as I said earlier, or if you get really bizarre, ugly anaplastic cells like this. So that would be a grade 4 ISUP WHO system. But it's important to remember that this grading system has been validated only for clear cell and papillary renal carcinoma. It has not been validated for any other renal carcinoma, and we should not use outside of these two settings. So here, this is a classic example of a clear cell renal carcinoma, and this is a classic example of a papillary renal cell carcinoma with macrophages in the fibrovascular course. So you use the grading system here. You do not use the ISUP grading system in chromophobe renal carcinomas. These are ungraded tumors, and I mean, the same would apply for other renal carcinomas like collecting duct or medullary carcinomas. We do not use the WHO grading system because these are universally poor actors and very aggressive cancers. So yes and yes for these two, no for anything else. All right. So let's discuss a little bit about some of the updates. So the first major update is in how we classify papillary adenomas. So we know that papillary adenomas are any tumors in the kidney that are less than 0.5 centimeters that have the appearance of a type 1 papillary renal carcinoma. But now the size threshold has been extended from the 0.5 centimeters to 1.5 centimeters. This is because many studies have actually shown that any papillary tumor that's low grade in appearance, if it's less than 1.5 centimeter, has no metastatic potential. So we have downgraded all these to papillary adenoma. So a simple example here, so you can see a cortically based tumor, which is a papillary lesion, which is 0.5 centimeter. Previously, it was called papillary adenoma, and even now it's called papillary adenoma. In this case, though, this tumor was previously called papillary carcinoma because it's more than 0.5 centimeter. But now, since we are calling everything less than 1.5 centimeter as papillary adenoma, this would qualify as a papillary adenoma. So that's the definition here. But it's important to remember that when you call a papillary tumor that is less than 1.5 centimeter as an adenoma, it has to be mandatorily low grade, right? And it should have something called as a non-syndromic morphology. So I'll go into this very shortly. We'll see what this non-syndromic morphology means. And then usually these tumors are unencapsulated. So here's this example that I showed you earlier. So if you look at it in higher power, you can see that there is no capsule here, and then it has got a very clear low-grade morphology. So these papillary, tubulopapillary structures lined by a single layer of cells, very bland appearing. So it has to be like that for you to call it as an adenoma. Anything that looks like a higher grade, we do not use papillary adenoma even when it's less than 1.5 centimeters. Okay, so what about on a needle biopsy? So this diagnosis can be suggested on a needle biopsy. However, you need to definitely correlate it with the imaging studies. If the CT scan shows that the needle biopsy that came out as a papillary tumor is less than 1.5 centimeter, you can call it a papillary adenoma even on biopsies. And obviously, there are no ancillary studies that will differentiate between these two. So this diagnosis actually may kind of seem trivial. So why are we making this change? It's especially important in certain conditions like when you're evaluating donor kidney. So in a donor kidney, if you call something as a papillary carcinoma, that kidney will not be available to be transplanted, right? But because of this criteria, now the recent criterion, even tumors that are 1.5 centimeters in size, so present in the donor kidney, can be classified as a papillary adenoma, and these patients will be eligible to donate. So the other change is in, again, downgrading of this entity we used to know as multiloculated cystic renal cell carcinoma. Now it's downgraded as a tumor of low malignant potential. This is again because it has studies have shown that this tumor, if correctly classified, has very excellent prognosis, and there are no reported metastases. So there is no point in still calling this a carcinoma. But we have to be aware of certain criteria before we label a tumor as a multiloculated cystic renal neoplasm of low malignant potential. So one of these important criteria is the cyst has to be lined by a single layer or at the most couple of layers of low-grade clear cells. And usually you find small clusters of clear cells in the septations. Okay, so let's take a look at some pictures here. So this is a tumor that is multiloculated cystic, and then you can see several septations. So let's look closer at the septations. You can see that the septations are lined by a single layer of clear cells, which have very low-grade cytology, right? And also inside the septations, you can see a few scattered clear cells. And then if you look at another area of the septation, you can see here the clear cells are clustering a little bit, but this does not form an expansile nest. It's a tightly packed, very small cluster, which is still acceptable in for this diagnosis. So it becomes important then to distinguish this from a low-grade multicystic clear cell renal cell carcinoma, because those can still metastasize. So The criteria that we use to differentiate these are in the septa, where you saw those small clusters of clear cells, there should not be an expansile growth. And then in the surface of the cyst lining itself, there should not be multilayering or any kind of complexity. And then thirdly, you should not see any features of regression or necrosis in the rest of the tumor area. So let's see how this looks like. So this case, for example, is again multiloculated cystic, but notice a difference in the lining cells. In some areas, you may see a single cell layered lining, but here clearly this is stratified and multiple cells lining this. So this is way too complex for you to call it low malignant potential neoplasm. And then here's another case where again it's multiloculated cystic, but clearly there is a lot of complexity in the cells lining. In fact, they are actually starting to form some nested growth pattern inside the lining itself. So both these cannot be called multiloculated cystic renal cell neoplasm of low malignant potential. And again, you see another example here where you have some septal growth of these clear cells, right? But the septal growth is not focal and it's not non-expansile. So you see this expansile growth occupying almost the entire thickness of the septation. So this will be your usual conventional clear cell renal carcinoma. And then finally, you may see some cases where it resembles multiloculated cystic, but you see areas in the stroma that show this type of hyalinization and fibrosis, which represent areas of regression of clear cell renal carcinoma. In fact, in this particular case, you can see a remnant nest of clear cells right here. So in these cases where the regression has occurred, it's more likely that these areas had clear cell clusters earlier, and it's more likely that they actually represented a clear cell renal cell carcinoma to begin with. So this also should not be called a multiloculated cystic renal neoplasm. So we have to be strict about these criteria. And obviously, because of these reasons, this diagnosis cannot be made on biopsy material. So let's next talk about papillary renal cell carcinoma. So this topic has become a little bit convoluted and complicated in the recent past because of the use of the substaging as a T1 or a type 1 and type 2 papillary renal cell carcinoma. So let's look at that in detail. So first point is that, as I mentioned earlier, the WHO ISUB grade is applicable in papillary renal cell carcinoma because it is predictive, right? And then we have acknowledged that the traditional type 1, type 2 classification is ambiguous. So what do we do about this, and why is it ambiguous? So in most cases, you do not see pure type 1 or type 2 features. In fact, a vast majority of cases are mixed histology tumors, and morphologic heterogeneity, even with this mixed pattern, is very common. And the initial definition that separated the type 1 and type 2 was very poorly defined. So it's all over the place, and nobody knows how to accurately classify these tumors. So let's look at some examples on what I actually mean. So this is a classic traditional type 1 papillary carcinoma. So you have these tubulocystic structures that are lined by a single layer of gland cells, very little amphiphilic cytoplasm, and you also have macrophage clusters in the core. So no problem, this is a low-grade PRCC, we can call it type 1. And on the other hand, you have this papillary carcinoma, which is very eosinophilic, abundant cytoplasm. You have high-grade nuclei that are in many places pseudostratified, and you don't have any macrophages in the core. So this would be classic appearance of type 2 carcinoma. Unfortunately, it's very rare to see this kind of pure appearance in papillary carcinoma. You might see this often though. Because what happens is many cases where you start seeing this mixed or ambiguous histology. For example, here you have a tumor that looks like a type 1. It's low grade, lined by a single layer of cells, but you get a more of a eosinophilic cytoplasm than amphiphilic cytoplasm. There is no blue appearance here. On the other hand, this case, even though it has a single layer of low grade cells, has abundant eosinophilic cytoplasm, unlike the definition for type 1. And in this particular example, not only do you have abundant eosinophilic cytoplasm, you have high nuclear grade, even though they are just single layer, and they also have macrophages in the core. So where do you actually put this tumor? if you go by the definition. And most cases actually start looking like this, because you have a combination of type 2 features and a combination of type 1 features or morphology that is in transition between the two types. So it becomes very difficult to classify this. There are a few more examples where you find clear-cut type 2 areas very adjacent to clear-cut type 1 areas. Right? Another example here, this is looking like a type 1 carcinoma, a tubule of a type 1 carcinoma, whereas this one with a higher grade nuclei, abundant eosinophilic cytoplasm, so the stratification basically looks like a type 2 carcinoma, and these are adjacent to each other. So basically, to solve this problem and trying to make it much more simpler, we did this study at the Memorial Sloan Kettering Cancer Center. We took a huge number of papillary renal carcinomas that had clear-cut type 1 features, but had type 2 features along with it. So essentially mixed tumors with type 2 features anywhere between less than 10% to greater than 90%. And what we found was there was no survival association with any amount of type 2 features. Even tumors that had more than 90% of type 2 areas did not behave worse than the tumors that had a very little or no type 2 areas. They essentially behave like type 1 carcinomas. And we also found that there was a shared mutational profile between the type 1 and type 2 areas. So as of now, these tumors with mixed features, if you see anywhere type 1 like areas, these are best classified just as PRCC and be assigned the WHO ISUP grade. So then what about papillary tumors that are purely type 2? What if you don't see any type 1 areas at all? So these, like by definition, lack the type 1 areas. And it's important when you come across these tumors to separate them from syndromic tumors with papillary architecture. So how do you identify these syndromic tumors? And what are these? So typically, as we know, this has been around for quite a while now, HLRCC carcinoma, hereditary leiomyomatosis, and renal cell carcinoma, which typically has a papillary architecture and has type 2 features. And then there are other tumors too that might look similar. This is the tuberous sclerosis associated carcinoma or SDH mutation associated carcinoma. So what we look for in syndromic tumors and how do we diagnose syndromic tumors for further follow-up will be to look for certain elements. So essentially, most of these syndromic tumors basically lack the macrophages, they lack frothy evacuation in the cytoplasm, and they don't have hemosiderin pigment, and they don't have that heterogeneous looking histology with degenerative changes that we usually see in papillary renal carcinoma, and they show some unique morphological features. So let me try to explain this better by showing you some pictures. So here you see a tumor which has macrophage clusters in the cystic areas and the fibrovascular course, and then you see the epithelial cells that look like type 2 with pink cytoplasm, high-grade nuclei, and some hemosiderin. And then you have another area where you have this frothy evacuation of the cytoplasm and the type 2 tumor. And you also you can see this frothy evacuation over here. And then what I mean by this degenerative change is exactly this. So you say areas of fibrosis, hyalinization, and degenerative type necrosis with cholesterol crystals, some bilirubin pigment. And you also have areas where there is clear-cut hemosiderin within the tumor cells. So this kind of heterogeneous features, this kind of degenerative phenomenon is usually not associated with syndromic tumors. These are actually just papillary cell carcinomas that have some of these type 2 like features. Okay. So what are these syndromic tumors? How do they look like? So I mentioned earlier that these have a homogeneous appearance compared to the ones I just showed. And you can see in these two pictures, the complete tumor is morphologically homogeneous. So they have these papillary formations, and each cell kind of looks similar to another. When you look closely at these tumors, you find other features, the so-called syndromic features. This tumor, for example, has these cytoplasmic blisters, right? Large vacuolations in the cytoplasm. And this happens to be a case of tuberous sclerosis associated renal cell carcinoma, which shows some type 2 papillary carcinoma-like features. And then this particular case, if you look closely, you will notice that it has quite remarkable enlarged nucleolus or macronucleolus surrounded by this punched out perinucleolar vacuolation. So we all know what this tumor represents. This is the HLRCC or hereditary leiomyomatosis associated renal cell carcinoma, or a fumarate hydratase gene mutated renal cell carcinoma, right? So this is, so to summarize papillary renal cell carcinoma, what are we going to do with these entities? First of all, you should know that the WHO ISUB grade is applicable to these renal cell carcinomas. And then type 1 papillary renal cell carcinoma is easy to classify. We just call them PRCC and assign them a low grade. And tumors which have mixed features, we are again going to classify them just as PRCC and assign them an ISUB grade. And then we are going to look for homogeneous type 2 features and work those up for syndromic associations. And tumors that are heterogeneous and have type 2 features should probably be classified the same way, just called as PRCC and be assigned an ISUB grade. So that is the current thought process on these entities. So moving on from PRCC, we have other new entities that have been introduced in the 4th edition of the WHO classification that were not there in the 3rd edition. And there are many, many such entities. I'm not going to go through all of them. However, I think it is important to discuss the most common entity that has been newly described. Right now, it's been around for quite a while, but we'll still look at some of the pertinent features of this clear cell papillary renal cell carcinoma. So this is a distinct morphologic and genetic entity, meaning it's distinct from both clear cell and papillary renal cell carcinoma. It has features that are common to both and that are different and not present in either. So morphology-wise, it's important to know that all these cancers are invariably uniformly low grade. And they have these clear cells which can be in tubules or in papillae. And the most important thing, as we all know, is the nuclear arrangement, which is a very peculiar linear luminal arrangement of the nuclei. So this is a prototypical image of a clear cell papillary renal cell carcinoma, where you have many tubules, some cysts, and also some papillary structures. So if you look closer at this, you will see the nuclear arrangement that I was talking about. So there is a linear arrangement of these nuclei towards the luminal aspect of these tubules. And you can see that in many, many places in this tumor. So there are some morphologic variations that can occur in the clear cell papillary RCC. For example, you can have some areas that have abundant voluminous cytoplasm like that, and you can have areas that have very little cytoplasm like this. It almost looks like a type 1 PRCC. And then there are areas where it can have a nested growth pattern looking like a clear cell RCC. And there are areas where you can get some atypia, but notice that all this looks like degenerative atypia, and this tumor is really not high grade. But the common theme in all these pictures is that if you look carefully, at least in some places, you should find the peculiar nuclear arrangement. For example, here you can see the linear arrangement towards the luminal aspect. In this one, you can see in several places over here. And also in this gland over here, you can see that arrangement. And even in these nests, if you look carefully, you will see that many areas in the nest have this type of luminal arrangement of the nuclei, and it's obvious in this case as well. So IHC is also very helpful in making this diagnosis because, as you can see, the differential includes both clear cell renal carcinoma and papillary renal cell carcinoma. This one is diffusely positive for CK7, which is completely unlike a conventional clear cell renal carcinoma, but similar to a papillary renal cell carcinoma. In contrast, if you use CA9, carbonic anhydrase 9, this is diffusely positive like a clear cell renal cell carcinoma, but completely unlike a papillary renal cell carcinoma. However, the pattern of CA9 is also very helpful in distinguishing this tumor from a conventional clear cell renal carcinoma. So let me illustrate with an example. So here is CA9. in a clear cell papillary renal cell carcinoma. And obviously, you can see that there is a diffuse and strong positivity in all the tumor cells, right? But the pattern of staining is very peculiar. You can see there is a lateral and basal staining, but no staining in the luminal aspect. So this is the so-called cup-like pattern of staining, which is different from the transmembranous or box-like staining that you get in a conventional clear cell renal carcinoma. So this pattern is helpful in making the diagnosis. And also, unlike a clear cell, it's going to be diffusely positive for CK7. So again, it's important to remember this is always a low-grade and low-stage tumor. Till date, no recurrence or metastasis has been documented, and therefore it is very important to distinguish this from a clear cell renal cell carcinoma. And in the upcoming edition of the WHO Blue Book, this tumor will probably be downgraded into a clear cell papillary renal neoplasm, because carcinoma, by most people's definition, is something that has potential for metastasis, which this one does not. So finally, in kidney, we should briefly look at some updates in the staging. This has happened in the T3A stage. So in the 7th edition, if you look at the T3 classification, it basically says T3A would be a tumor that extends in the renal vein or its muscle-containing branches. In the updated version, it has been accepted that there need not be essentially muscle in that segmental branch. Any segmental branch, essentially any large vessel that's present in the renal sinus, if there is tumor in it, it can be classified as a T3A. And also, it's been included that tumors involving the pelvic calyceal epithelium should also be classified as a PT3. So a couple of quick examples here. So this is a large branch of the renal vein or the renal vein itself, and there are some smaller large vessels which are segments, but they do not have the muscular lining. So if a tumor involves this, it will still be a T3A. And again, example here of the renal sinus, where you have several veins, larger ones which are partially musculated, and then larger ones which do not have any muscle at all and just lying in the sinus pad. So T3A would be for any tumor that is present obviously in the renal vein, as you can see here, or if you find them in the muscle-containing branches of the renal vein, as you can see here. And now you can also call T3A when you have tumor embolus or thrombus present in the non-muscle containing branches of the renal vein, as long as they are large and they are present in the renal sinus pad. And here's an example, another example of the same phenomenon. All these will be PT3A. And then lastly, it's been included that renal cancer, which directly extends and involves the pelvic calyceal urothelium, should also be classified as a T3A. So here in this example, you can see there's even a pagetoid spread in the calyceal urothelium over here. So in most cases that involve the renal sinus and then involve the pelvis are also going to involve the renal sinus. So that's easy to diagnose as the T3A in that setting. But in some cases, in the smaller calyces, you can have direct contact of the kidney with the calyceal system. And in those situations, you have to look carefully and see if it's involved in the calyceal system, because you can assign T3A grade stage even in that situation. So that's the end of the kidney session. We can continue on with the testis. So this is just an image of the fall colors in the northern hemisphere. It's really very beautiful. You get all shades of yellows and oranges and reds, but it lasts for only a couple of weeks. So let's move on to updates in testicular pathology. So in testis, I'll flip the outline a little bit, because I think the staging updates in testis are a little bit more important and somewhat controversial compared to the updated entities themselves, which are in their own way very interesting, but I wanted to discuss the staging updates first. So there is an expansion of the PT2 stage. So essentially earlier, we used to classify all testicular tumors that had either LVI or tunica vaginalis invasion as PT2. Now we have also included tumors that extend into the testicular hilum as PT2. So this is what we were doing earlier. So here you can see a tunica albuginea, and then a covering tunica vaginalis membrane over here. And then just below the tunica albuginea, you get this large vascular space. It's a typical place where you find lymphovascular invasion, and this would be a PT2. And similarly, this is a much more uncommon phenomenon. Here you see a yolk sac tumor that's actually invading and involving the tunica vaginalis. So this would be a PT2. So as I said, now we have expanded this to involve tumors invading the hilar soft tissue. So here is an example of how that might look like. So this is a section from the hilar region of the testis. So you can see a well-defined tunica albuginea here, which gets broken up into an ill-defined membrane by the rete testis going through the testicular covering and joining the efferent tubules, which then would join the epididymis. So there is this tumor here, and I have to tell you that I took some artistic liberties here, and just to illustrate the examples. So you can classify something as a PT2 when it's invading directly through the tunica albuginea and then involving the hilar soft tissue. So that is easy to diagnose because the plane is very well defined here. However, in this area where the tunica albuginea is not well defined, it gets a little more difficult to define the plane. So in this example over here, you can see that the tumor is involving clearly the hilar fat, so that's easy to diagnose. However, there are many areas in the testicular hilum that do not have a lot of adipose tissue. So in an example like this, it might become difficult. So what I would suggest can be done in these cases is to try and follow the contour of the tunica albuginea right here and follow the curvature and kind of draw an imaginary line which crosses across to the other side. And anything that's beyond this imaginary plane should be called as a PT2, and anything that's within that plane should be called as a PT1. So let's look at some more examples here. So in this section, you see there is a lot of fat in this area of the testicular hilum compared to the right side, where you find the efferent ductules and only connective tissue, fibrous connective tissue, and not adipose tissue. So if there is a tumor which is involving the testicular parenchyma here and not involving the albuginea, it can be called as a PT2-1. That's easy. But in conditions where there's like a tumor on the fence like this, when it's slightly extending outside, but you're not sure whether it's going in or not, especially in areas which do not have fat like that, it becomes difficult. And again, what you can do is draw an imaginary line connecting the two ends of the tunica albuginea and try to form a plane. And if you can decide that the tumor is beyond that plane, you can call it as a PT2. And these are some real life situations here illustrating that example. So you can see a seminoma that is extensively involving the rete testis, but not going into the mediastinum. So this would be a PT1. And in this example, you can see a seminoma that is extensively involving the tunica albuginea and the hilar area. And if you observe carefully, you can also see that it's extending into the hilar adipose tissue. And this would be a PT2 in the new staging system. Okay. And then the other staging update, which is controversial, is the PM1 stage expansion. So everybody knows we designate a tumor as M1 if there is distant metastasis. However, in the testis, the new AJCC system included this particular clause that if you have a discontinuous invasion of the spermatic cord via a lymphovascular invasion phenomenon, then you can call it PM1. So this became very controversial. Let's look at an example here. So you can see a section of the testis and an associated vas difference. So whenever you have vas difference in the connective tissue adjacent to the testis, then it means you're actually looking at a section of spermatic cord adjacent to the testis. So when there is a tumor that's involving the tunica albuginea and going into a connective tissue section that also contains the vas, you know it is a spermatic cord invasion. And here is a gross picture which clearly shows you that the tumor is directly extending into the spermatic cord. So this is simply classified as a PT3, as we have always done. So that's the easy part of it. So now we have another tumor over here, which is actually involving the spermatic cord as an LVI, right? So this is just LVI, and according to the current classification, we would just call it PT2, just as we saw LVI inside the testis itself. It would be the same. There could be a situation in which this LVI is so extensive. So here again, you see a section of the spermatic cord, and then here you see a vessel, and there is a thrombus, the tumor thrombus LVI, and this thrombus actually involves the wall of the vessel and actually gets out into the surrounding connective tissue. So this is a situation where the AJCC staging said, instead of calling this T3, we should actually, and this is, by the way, a hormone section of the same, which actually shows you extensive invasion of the spermatic cord soft tissue. So the AJCC classification says this should actually be called as M1 because these tumors behave like metastatic tumors, right? So the thing is, they made this suggestion without a really good evidence. So the evidence that is in favor of upstaging this is actually poor. In fact, there have been some studies that have come out in the recent past that have actually said that this is not true at all. And the combination of these two studies shows us that LVI in the spermatic cord, whether it's with soft tissue invasion into the spermatic cord or without soft tissue invasion, both behave like PT3 tumors. So essentially, what they are saying is that PM1 stage should be just left as it is. That is only when you see distant metastasis. And if you see involvement of the spermatic cord via LVI, these tumors behave like PT3. So essentially, this tumor, which involves the spermatic cord by LVI and extends out into the soft tissue, should be a PT3. And the same would apply for this tumor, which has lymphovascular invasion, but is only confined to the vessel. So this tumor also behaves like a PT3 and not like a PT2. So this is the current, I wouldn't say recommendation because it's not official yet, but it might happen in the next edition. All right, and then finally, a much simpler change is the PT1 subclassification just for seminomas. So it was found that tumors, the seminomas that are lesser than 3 centimeters, behave much better than seminomas that are greater than 3 centimeters. So it is essential that we subclassify seminomas according to the size as PT1A or 1B. So let's now look at some new entities and updated entities in germ cell tumors. So the most important change in nomenclature was with the terminology of ITGCN, which is basically intratubular germ cell neoplasm. So this is now replaced by a much more acceptable term called GCNIS, which is germ cell neoplasia in situ. This is because the ITGCN terminology was confusing. It not only included germ cell neoplasm, in situ germ cell neoplasms that were confined to the basal layer, but also entities such as intratubular seminoma and intratubular embryonal carcinoma, which were clearly not in situ malignancies. And also it included the carcinoma word, which we know that the germ cell tumors not actually carcinomas, but they are germ cell neoplasms. That terminology is changed. And then this is important to understand. The germ cell tumor classification has been clarified and revised into two major subcategories. One is germ cell tumors that are GCNIS derived, that are preceded by a germ cell neoplasia in situ, and those tumors that do not have any association with germ cell neoplasia in situ. So these GCNIS derived tumors are typically malignant. They arise typically in the postpubertal testis, and they all have chromosome 12p overexpression in the form of isochromosome 12p. In contrast, the non-GCNIS derived tumors are all benign or have indolent behavior, typically arise in childhood in the prepubertal age group, and they have normal chromosome 12. So if we look at this more in detail, you'll see these two classifications. Basically, the GCNIS derived tumors are all postpubertal tumors, and these are the ones that we are most familiar with, the seminomas, embryonal carcinomas, and all the other ones, as well as mixed tumors. The non-GCNIS derived tumors, typically, as I said, arise in the prepubertal age group. They're usually pure teratomas or pure yolk sac tumors in children that behave in a benign or indolent fashion. Occasionally, you may have a mixture of teratomas and yolk sac tumors. And the newest item that is a little bit difficult or to understand is actually the postpubertal teratoma, which is a non-GCNIS derived tumor. So we'll talk more about this in detail, but we also should know that the entity that was previously called as a spermatocytic seminoma has now been reclassified as a spermatocytic tumor, because this is not GCNIS derived tumor. It occurs in the postpubertal age group, and it has very little or no metastatic potential, so this should not be classified as a malignancy. So the spermatocytic tumor, as I was saying, the seminoma designation has been removed. So this also means that we no longer have to call our usual seminoma as classic seminomas, because there is nothing other than, there is no non-classical seminoma because this entity is gone. And as I said, this rarely metastasizes unless it has sarcomatoid dedifferentiation. That happens very, very rarely in these spermatocytic tumors. So that's the only situation in which they behave in a malignant fashion. And in most cases, orchiectomy alone is curative. So this is a classic example of a spermatocytic tumor. So you will see the seminiferous tubules, even though they are atrophic, they do not show GCNIS. And if you look closer at the tumor cells, you will see the classic three different types of cells, where you see small cells that look pretty much like lymphocytes with condensed chromatin. And then on the other end, you see very large nuclei that have very open chromatin, and then cells in between. So this is an example of a spermatocytic tumor that typically occurs in older males. And then this concept of prepubertal type teratoma and postpubertal type teratoma is important to understand. So the prepubertal, as I said earlier, are non-GCNIS associated tumors, and they are completely benign, and they behave in an indolent fashion. So they typically have organoid features, okay? So partially formed organs, and I will show you some examples. And they do not have any dysgenetic features in the adjacent testis, such as fibrosis or scarring or microlithiasis or atrophic tubules or Sertoli-only tubules. They do not typically show that. And among the teratomatous elements, there is no atypia in the cells, and there are no immature elements. And obviously, they do not have the isochromosome 12p mutation. In contrast, the postpubertal teratomas are all GCNIS associated, and they are all malignant. It doesn't matter whether they are mature or immature. They all behave in a malignant fashion. So let's look at some pictorial examples here. So here is a teratoma in a testis, and you can see the cyst lining, which is composed of ciliated respiratory type epithelium. And then in the adjacent testis, you do not see any evidence of GCNIS. In contrast, this case, it has a squamous cyst lining producing some keratin. And you can see the seminiferous tubules adjacent to that, which are clearly showing GCNIS. Okay. And then in this case, other areas of the testis showed prepubertal type seminiferous tubules. Okay, so this is in a prepubertal setting, whereas in this particular patient, the adjacent testis shows features of dysgenesis. This is what I was talking about. So you get this microlithiasis, you get areas of scarring, you get atrophy, complete atrophy of the seminiferous tubules, or sometimes you get partial atrophy with Sertoli-only cells. So you find areas of dysgenesis. And then if you look at the teratomatous elements, we'll see that they have this organoid pattern. So this could be just a section from either the bronchus or trachea, where you find the squamatized respiratory epithelium and the underlying smooth muscle layer and these well-formed mucus glands with very bland cytology. In contrast, in postpubertal teratomas, you see these very ill-formed glandular elements that do not represent any forming organ. And you also see atypia, and if you look closely, you might see even some mitotic activity. So this is immaturity and atypia. And then finally, if you do a FISH study, you'll find the prepubertal ones are all normal. They have normal copies of chromosome 12. In contrast, if you look at the postpubertal teratomas, they all have these additional copies of chromosome 12 because of the isochromosome 12p phenomenon. So this is a benign prepubertal teratoma. This is an example of a malignant postpubertal teratoma. And finally, there is this entity called the cystic trophoblastic tumor, which is an addition to the new WHO addition. So this cystic trophoblastic tumor essentially morphologically consists of cystic elements that are lined by squamoid-looking mononuclear cells. And they classically have this cytoplasmic vacuolation. And if you look closer, they do look very atypical because the nuclei are enlarged and abnormal, but you can see that the chromatin as a whole is smudged. So this is an example of a degenerative type of atypia, right? So these are typically seen in a metastatic setting in the retroperitoneal lymph nodes in patients who have received chemotherapy for germ cell tumor. So the thinking is it likely represents a regress choriocarcinoma, or it is a germ cell tumor element that is transforming to a teratoma. Occasionally, you might get some beta-HCG positive cells in this lesion. So the key element to understand about the cystic trophoblastic tumor is to diagnose it correctly. Because it has indolent clinical behavior, it essentially behaves like a mature teratoma in the setting of a post-chemotherapy lymph node resection, meaning this patient does not require any additional chemotherapy if you find just this or a teratoma in the lymph node. So this brings us to the end of both the sessions, and thank you very much for your attention. And if there are any questions, please.
Your teacher, Dr. Krishnan Iyengar, has complimented sharp and clear, brilliant as ever. That was really, really amazing session.
Thank you, Krishnan.
There is one question, I think. There's one question from Dr. Suma Seshad. Yeah, with HLRCC, is it always leiomyoma that is associated or leiomyosarcoma?
So it's typically leiomyomas. So there is a concept that there are some papers that have been published that have actually said that there are leiomyosarcomas that carry the same mutation, which you find in leiomyomas, but they are much less common compared to leiomyomas. So I wouldn't say they never exist. It's possible, but they are very rare. It's mostly just leiomyomas that you find.
Another question from Dr. Vikram Raj Gopinathan. Germ cell tumors with diffuse involvement of testicular parenchyma, where after extensive sampling epididymis is not identified. What is the stage and impression given in the report?
So in this case, I think the growth assessment is very important. So you have to go back to the grossing bench and you have to talk to the person who grossed this and look at some gross photographs if possible, because that will clearly show that the tumor is not confined to the parenchyma and has involved the epididymis. I agree, microscopically, sometimes it might be very difficult to identify if it's completely replaced, but in the gross assessment, you should be able to tell it's outside of the testis.
There are some other compliments. Professor Gandhimati Madam has said, excellent speaker with great clarity of thoughts. Thank you very much. And Dr. Vinay has said, excellent presentation, Dr. Paari Murugan sir. And then Dr. Manoj Kaha, two great, very useful and informative tips given, highly obliged by your teaching today. And Professor Tanka Madam has congratulations, nice and informative sessions. and Professor Padmavati Madam, IAPM, crisp and clear concepts, excellent sessions.
Thank you. Appreciate it. Welcome.
All to the inauguration session of the CME. I invite the organizing chairperson of the CME, Professor and Head of our department, Dr. Vijayashree, to welcome our special guest speaker and participants and inaugurate the CME.
Thank you, Dr. Samila. In fact, it's a very warm Saturday, sunny morning after 1 week of rains here in Chennai. And it is so happy to have a session like this, such a huge academic session and such a nice speaker. It is really wonderful. I think all the participants here now already realized that what is the charisma of the speaker. So we really don't need any interaction at all with the speaker now. Anyway, coming to the welcome. On behalf of Department of Pathology, CHRI, I extend a great, and a warm welcome to all the participants. And first of all, to our esteemed Vice Chancellor in charge, Professor Meenakshi Ma'am, who's here with us. And the speaker, second is the most important speaker. We already know who the speaker is and what is the level of the session which went on. So a very warm welcome to you, Dr. Paari. Coming to Madam Meenakshi Ma'am, actually she's a very, very warm, very gentle person. And she's a clinician herself, and she's an expert pulmonologist. And she's just not a clinician, I should say. She's got a great interest in academics, and she's also a great researcher because Madam has got many ICMR projects and as well DST and DBT projects as well. And she's a very, very active member of National Tuberculosis Program, NTP. She's even now very active in that, and she's, she takes a great interest in disseminating this program and also make sure that the patients do get benefited with this. So Madam is a very, very keen academician as well. And due to internet issues, our dean has not, he couldn't join us. Otherwise, he's on call. So a warm welcome to our dean, Dr. Paari Murugan as well, who's been a great support in all these academic events for us. And next, all the participants. This is, I am so glad and so happy to see so many of them, not just from Chennai and even from Pondicherry and other places of India, especially from JIPMA. And I welcome all my mentors, my teachers, my friends as pathologists and my colleagues and my dear students. And from JIPMA, if somebody wants to say a few words for Dr. Paari Murugan, because I know he was a very favorite student of all the JIPMA professors at that time. So if somebody wants to give a small 2 or 3 words about Dr. Paari Murugan, they are welcome now. And also welcome other postgraduates from the other institutes for this particular session. So Dr. Femila, I will invite Professor Meenakshi Madam. Madam, Professor Meenakshi Madam.
Can you hear me?
Yes, ma'am.
Dr. Vijayashree?
Yes, ma'am. Yes, ma'am. I invite our esteemed Vice Chancellor in charge of care to give a welcome address.
Thank you, Ma. Thank you for your kind words. Good morning, everyone. I am privileged and honored to be part of this international CME on updates in genitourinary pathology on the occasion of the International Pathology Day 2021. We all know pathology is a science that bridges the basic science with the clinical sciences. I can rightly call pathologists as detectives in the field of medicine as they unmask various clinical diagnoses. As we all know, right patient care starts with the right diagnosis, and pathologists, they form the backbone for the proper diagnosis, even though they are in the background. Every year, this International Pathology Day is observed to create an awareness and also to sensitize the maternal medical fraternity on the recent updates in the field of pathology. I think this year we are honored to have Dr. Paari Murugan. I was actually listening to him. Some of the lectures I was listening to him from US. He is a world-renowned pathologist, distinguished scholar. I think he is an excellent teacher and he has authored many books. His achievements is running to so many pages when I saw those, his curriculum vitae. Actually, we are overwhelmed with joy to note that our distinguished speaker, Paari Murugan, is from India and especially from Tamil Nadu. On behalf of our university, that is Chettinad Academy of Research and Education, I extend a very warm welcome to our speaker, Dr. Paari Murugan. I also congratulate the HOD and the organizing team for selecting such an eminent speaker and for also selecting such an eminent topic, the genitourinary malignancies. Even smoking is one of the causes for genitourinary malignancies. As a clinician, I know this is almost 1/5 of our malignancies, even in India, prostate cancer, renal cell cancer. I think this topic is an apt topic for selected for this CME. I congratulate once again all the organizers and our warm wishes to Dr. Paari Murugan from our university and from our hospital. Thank you, ma'am. Thank you, Jishnu.
Thank you so much, ma'am.
Thank you, ma'am, for your very warm and kind words. I can assure you that I am nowhere close to a world-renowned pathologist.
No,
I have a very long way to go, but
actually,
I will try.
When I was going through your curriculum, it was going on and on and on and on. We are very, very fortunate and happy to have you here, sir, at our university.
He's a very passionate teacher as well, ma'am.
Yeah,
I mean,
yeah.
as you could see in this one,
yeah, so many awards as an excellent teacher. That is very, very important. That's really
ardent researcher as well. I mean, basically, sir is from JIPMER, and that's why I thought if somebody from JIPMER can just say a few words about Dr. Paari Murugan, because
that is also, he is anatomical pathologist, I heard. So that is also very nice, actually. Very nice. Our wishes from our Chettinad University, sir. Thank you, ma'am. Thank you, Dr. Jishri.
Thank you so much, ma'am. Thank you. And since the dean is not here, I would like to call Dr. Rajesh Khanna to just give a vote of thanks. And before that, Dr. Femila, can you give the introduction of the speaker? I mean, it's going to be.
I'm truly honored to introduce the speaker, who was my senior and mentor. Okay. Dr. Murugan is an associate professor at the University of Minnesota Medical Center in Minneapolis, USA. He is an American Board of Pathology certified anatomic pathologist whose area of expertise is in the surgical pathology of genitourinary and bone and soft tissue tumors. After pathology residencies at JIPMER, India, and the University of Oklahoma, USA, where he was chief resident, he completed fellowships at the MD Anderson and Memorial Sloan Kettering Cancer Centers in the USA. In his current position, in addition to the clinical diagnostic role, Dr. Murugan is involved in medical student, resident, and fellow education, as well as translational research. He enjoys teaching and is constantly engaged with residents and fellows with interactive discussions during daily synods and conferences. In acknowledgement of his contribution, he was conferred the Anatomic Pathology Teacher of the Year Award in 2015, 18, and 21. Dr. Murugan has contributed over 70 peer-reviewed publications, numerous scientific meeting presentations, book chapters, and has lectured nationally and internationally. He is involved in multiple NIH research grants and is an associate editor for the journal Diagnostic Pathology, an ad hoc reviewer for several journals, including Journal of Urology, BMC Cancer, Lectures Archive, and Human Pathology. He also serves as an elected member of the College of American Pathologists Cancer Committee and as medical director of the University of Minnesota Clinical and Translational Science Institute's Biorepository and Laboratory Services. He received the Scientific Society Gold Medal for the Best Research Project in the year 2007 and 8 at Jawaharlal Institute of Postgraduate Medical Education and Research, JIPMER, India, and Nalini Bai Thakur Award for the Best Platform Presentation in the year 2007 at the 37th All India Annual Conference of Cytology, Allahabad, India. He was our kind senior, always motivates and inspires the juniors, and a good student who makes his teachers proud. I'm pretty sure that he would have justified and would justify to our expectations for today's CME.
Thank you, Femila, for the warm and kind words. Thank you very much for inviting me here.
I invite Dr. Rajesh Khanna, Professor of Pathology, to deliver the vote of thanks.
Thank you, Femila. Professor Dr. Rajesh Khanna, on behalf of Department of Pathology, CHRI, proposing very hearty vote of thanks to the International CME on updates in genitourinary pathology in commemoration of celebrating the International Pathology Day 2021. It's an excellent lecture by Sir Paari Murugan, sir. I extend a very hearty vote of thanks to Paari Murugan, sir, for sharing with us his findings and opinion today. I also extend our warm hearty thanks to our Honorable Chancellor, Vice Chancellor, and our beloved Trustee Chairman, Registrar Ma'am, for giving us all the support and guidance in conducting this CME successfully. I also thank our faculty members, postgraduates, all the beloved participants of this CME, and not the least, IT who has given us the support of conducting this e-seminar or the e-CME successfully. Thank you, one and all.
Thank you, sir. I welcome Dr. Paari Murugan to continue the session of a slide discussion.
So I have 4 interesting cases that I came across in our practice, and each of these cases belong to one separate organ system. I've selected one case from the bladder, one from the kidney, one from the testis, and one from the prostate. So I found these cases very interesting and thought-provoking. So I wanted to share them with you, and I hope you will feel the same about them. So case 1 is from the prostate. This is a 65-year-old male patient who presented with elevated PSA on screening, and he had standard transurethral ultrasound-guided biopsies performed. So you can see one of the biopsy cores here, and this area is benign. There is clearly something abnormal going on from this end to this end. So if we take a closer look at what's happening, so you can see glands over here that are pseudostratified, and they are discrete glands. They do not look normal at all. They look malignant. They could be something like a high-grade pin. And if you look closer, they are clearly atypical, and higher power picture even shows some apoptotic activity. And I do not see mitotic figures, but this is clearly abnormal. And if we go to the other areas, so the left side of this particular entity, we can see that there are more discrete glands here, and most of them seem to have lesser stratification than we saw on the right side. Many of them single cell layered, and then, so you can see this better over here. And there are also some cells that seem to have this granular material in them. And if you go to the extreme left, you find that they become very poorly differentiated glandular structures. In fact, one can hardly see any glands at all, and it becomes like single cells and linear streaks of cells involving this fibrotic stroma. So clearly, there seems to be some cancer here. But let's see what our immunohistochemical stains are showing. So here is an immunohistochemical stain for high molecular weight keratin. And you can see that in this area, there are some basal cells that are still retained, but many of the glands have actually lost their basal cell staining. Okay? So if you move further towards the left in that core, you can again see many of the glands that are actually retaining the basal cell stain, whereas in the left corner, most of them seem to have lost it. And then if you move towards the far left, where we saw all those poorly formed, ill-formed glandular structures or no glandular formation at all, a vast majority have actually lost the basal cell staining. So what are the differential diagnoses that we have at this point. So clearly this is not benign. This is some kind of a malignancy, but what diagnosis are we going to give it? So we could think, okay, maybe this is just the usual adenocarcinoma because of the poorly formed glands where hardly any lumens are seen because of almost a single cell appearance or the linear streaks of cells. Maybe we should assign this a Gleason pattern 5. And then the other area which showed the stratification and glandular epithelium, perhaps that's just Gleason pattern 3, which is more like a pin-like ductal Gleason pattern 3. So this pin-like ductal carcinoma is a variant of ductal carcinoma of the prostate, which behaves like a Gleason pattern 3. So it looks like a high-grade pin, but many of the glands we saw had lost the basal cell staining, so it could be a pin-like ductal carcinoma. So maybe the overall Gleason score here, if you include 3 for that and 5 for the other areas, it's a Gleason score 8, a grade group 4 cancer. Okay, so that's one differential diagnosis. But how about Gleason score 9 carcinoma? So you could consider like, okay, the Gleason pattern 3 areas are not actually pin-like ductal. Maybe they are the regular ductal carcinoma, which would in fact be categorized as a Gleason pattern 4. So in that case, you would get a Gleason pattern 4 plus 5 carcinoma, which becomes a grade group 5, right? Are there any other diagnosis for this lesion? Could this be something else altogether? So let's take a look. So these are 2 stains have been done on this particular core, and these, as you can clearly see here, there is a diffuse and extensive positivity for both these stains, right? So what are these stains? This is actually synaptophysin and chromogranin. So as we well know, these are very good neuroendocrine markers, and it looks like the whole cancer or whatever it is completely neuroendocrine, and you can see the synaptophysin even in areas that are very poorly differentiated that look like Gleason pattern 5 are strongly positive for synaptophysin. So at this point, we have to reconsider our differential diagnosis because now we have started to think of some neuroendocrine entities in the prostate. So could this be a usual adenocarcinoma of prostate as we decided previously? Maybe a Gleason grade 4, maybe a grade group 4 or a grade group 5 cancer with some neuroendocrine differentiation. That's one possibility. Other possibility is, could this just be a plain neuroendocrine carcinoma of the prostate? If so, what type? Like a small cell carcinoma, large cell neuroendocrine carcinoma, or something else altogether? That's one possibility. And then there is another entity that we all know as prostatic adenocarcinoma with Pennant cell-like neuroendocrine differentiation. So could it be that? So these are all the possibilities that we have at this point after we saw that the synaptophysin and chromogranin were diffusely and strongly positive in the tumor cells. So let's have a brief discussion about neuroendocrine differentiation in prostate carcinoma. So typically we see neuroendocrine differentiation in most usual prostate carcinoma. It's just that we don't do neuroendocrine stains in that setting because we don't think it will be useful, right? But if you do the stains, you will see that many prostate carcinomas will have some cells that are positive for synaptophysin and chromogranin, and this has no implication. And then we will discuss this other entity. And as all of us know, there are also small cell carcinoma and large cell neuroendocrine carcinoma that can occur in the prostate, and rarely you can get carcinoid-like tumors as well in the prostate. So these 2 entities are very uncommon. So let's look a little bit more in detail about the other entities. So as I mentioned, usual prostate carcinoma can often have neuroendocrine IHC positivity, and it's not uncommon at all. And this has no prognostic significance, so this should not be overdiagnosed as anything other than regular prostate carcinoma. So let me show you an example here. So this is a high-grade prostatic carcinoma. It has got all these poorly formed glandular structures, and also many areas it's called single cells and linear groups of cells. So I would classify this as probably a Gleason pattern, grade group 5 carcinoma with either 4 plus 5 or 5 plus 4. So if you do a synaptophysin staining, you will see that few of the cells in this cancer, or this area, are showing some neuroendocrine pattern staining. But this cancer does not have any appearance of a small cell or large cell carcinoma, and this type of scattered neuroendocrine marker can just be ignored. And then we also have true small cell carcinomas of the prostate. In most cases, this is intermixed with the usual carcinoma, right? So many people think that there is basically a transdifferentiation, that the regular prostate carcinoma slowly acquire genes that make it transdifferentiate, or mutations that make it transdifferentiate into a neuroendocrine phenotype. And in many cases, it may also occur after androgen deprivation therapy for prostate cancer. So a process called clonal selection may occur in this case, where all the cancer cells, the usual prostate cancer that are responsive to ADT die off, and what remains actually starts propagating, which is the neuroendocrine phenotype, which does not respond to ADT. However it occurs, this, like all other small cell carcinomas in the human body, has very aggressive behavior, and it's pretty much treated with platinum-based agents like small cell lung carcinoma is treated. So one has to note that often it can mimic Gleason pattern 5 because it will grow in sheets, but this is not assigned a Gleason score. Small cell carcinomas are just called small cell carcinomas, and that's about it. So here is an example. So this may not look like a typical small cell carcinoma that you might see in the lung because it has too much cytoplasm, right? But if you look closely, you will see that many of these cells, or all of these nuclei, have this coarse salt and pepper type of chromatin, very inconspicuous or small nucleoli, and then multiple easily identifiable mitotic figures and apoptotic debris. And in this case, if you do a synaptophysin immunostain, you will see a strong and diffuse positivity. So this shows that despite the fact that it does not have classic morphology like a small cell cancer of the lung, this is a transdifferentiating form of small cell cancer where the acinar cells are actually acquiring a neuroendocrine phenotype, and it will essentially behave like a small cell carcinoma. So this will be diagnosed as small cell carcinoma. But how about this entity called prostate carcinoma with Paneth cell-like neuroendocrine differentiation? So these Paneth cells, which we find in the intestine, are these neuroendocrine granules, and sometimes we can see them in the prostate gland cell if you look carefully. So in this example, you can see a couple of benign glands in the prostate with the gramulacia. In the bottom layer, you can see these neuroendocrine, very pink eosinophilic granules. So these are the Paneth cell-like neuroendocrine granules we see in the prostate. And coming back to our case, so again, if you go back and look carefully at the areas which look like high-grade PIN, you can see isolated granulated cells over here, right? And this is much more visible if you go to the left of that biopsy that I was showing, where it looked more poorly differentiated. Many of you might have noticed these eosinophilic cells with this brick red granules, right? So these are essentially the Paneth cell granules. And then in the much more poorly differentiated areas, it is a little bit difficult to identify, but they are still there. And in fact, the stain identifies them far better than the morphology. It's essentially showing pretty much most of the cells has this type of differentiation. So it proves to you that this is a Paneth cell-like neuroendocrine carcinoma of the prostate. The important thing here to realize is it can mimic high-grade prostate carcinoma, as we saw. So if we did not see Paneth cells in this particular case, this would be equivalent to a Gleason pattern 5 or Gleason pattern 4 carcinoma. But a case with Paneth cells like this is not a high-grade carcinoma. It has very indolent behavior, and therefore it should not be assigned a Gleason grade at all. So the final diagnosis on this case is a prostatic carcinoma with Paneth cell-like neuroendocrine differentiation, and this should always include a note or a comment to the surgeon that this will not be assigned a Gleason grade or a grade group because it behaves in a very indolent fashion, and these patients should just be put on. Any questions on this case?
Dr. Paari? Dr.
Yes.
Paari? I have a question.
Yes, I can hear you.
Yeah, regarding the markers of synaptophysin and chromogranin, do you apply it regularly for all the malignancies in the prostate, or it is just that only when you identify these cells you apply these IFCs?
Yes. Yeah,
because
exactly.
Those few
so,
granulated cells is very difficult to think of neuroendocrine.
Absolutely. You're absolutely correct. It is very difficult to think of neuroendocrine because they are very few and far in between, and one may not even notice them, right? But the distinct brick red granules should catch your attention because they are so unusual. But once you see them, your mind should automatically go back to, okay, I know there is something called this Paneth cell-like neuroendocrine differentiation in prostate, so maybe this is what is representing, right? So in that situation, you can go ahead and confirm it with synaptophysin and chromogranin. But to answer your initial question, I certainly don't do synaptophysin and chromogranin on all my cases or most of my cases, just hoping that one of these cases will turn out to be this, because the morphology always trumps the IHC. Our morphological findings should come first, right?
Sir, I have got one question, sir. Should we have to do neuroendocrine markers for all the poorly differentiated pattern of adenocarcinoma, prostatic adenocarcinoma?
Yeah, that's a great question. So I think it is not wrong to do that at all. The reason I say that is because most of these prostate cancers that are poorly differentiated, they will start treating them with androgen deprivation therapy, either through surgical means or through medical means, right? And that therapy will not work at all if there is extensive neuroendocrine differentiation. And these patients would need platinum-based therapy. Okay, so instead of the oncologist wasting time first treating the patient with ADT and then finding out in 6 months that the patient has come back with extensive metastasis, it might be good on our part if we actually do these neuroendocrine markers on these poorly differentiated carcinomas, just in case to see if they're going to be synapto and chromo positive. If they're going to be extensively positive, and that word extensively is very important here. It's going to be extensively positive, and you also see features of a small cell carcinoma, then you can call it neuroendocrine differentiation, and so the oncologist will be aware that they have to treat this patient with platinum-based agents, and ADT will not work in these patients. So I would say yes, yeah.
Thank you for enlightening us.
Okay, there are no other questions. We can go on to case 2.
Of PSA in these. What would be the role of PSA?
Yeah, so that's a good question. So this patient actually had an elevated PSA. So these cells still produce some. These cells are still associated with some prostate glands, so they still produce some PSA. Would be by guess. But as we know, PSA is not a very specific marker for prostate cancer, right? Many benign conditions in the prostate can increase the PSA. So it is possible that the PSA elevation in this patient did not actually come from these neuroendocrine carcinoma cells, but it was just coincidental, and they just happened to notice the cancer because he came in for screening. But yeah, that's a good question. So these neuroendocrine cells as such should not be elevating the patient.
Thank you. May not be related to this case, but I just wanted to know the expression of PSA in testicular. So if they do architectomy for prostatic malignancies, right, for hormone ablation. So by chance we see some cells which are little abnormal, and we apply PSA in those cells in the interstitium. And if they are positive, so what is your comment on that? We want to distinguish between Leydig cells and these malignant cells.
So you're talking about prostatic cancer metastasizing to the testis?
Testis, right? Yeah.
Okay, so that's a very rare phenomenon, although I have to say I've seen a couple of cases. So in this situation, the marker that I would prefer is NKX 3.1. So that is a way more sensitive and specific for prostate cancer in this setting than PSA, because in most metastatic settings, the prostate cancer expression of PSA gets reduced, and you may not see discernible PSA expression. You have to really look very closely at the immunostain, and any brown should make you think it's positive, right? But these days, NKX 3.1 is the preferred stain, and as I said, it's much more specific and sensitive than PSA, and that's what I would use, and that should help you differentiate between the other cell types and prostate cancer.
Okay, yeah. So even Leydig cells in the literature says can express PSA to some extent. So you cannot really distinguish between.
Yeah. To be honest, I don't really use PSA these days. We like this complete transition to NKX 3.1 in our lab.
Okay. Okay. Thank you.
Sure. All right, so let's go on to case 2. So this will be a testicular tumor. So this was a 29-year-old male patient who presented to us with a testicular mass, and only LDH was elevated. He did not have AFP or beta HCG elevated. And as is a standard protocol, any young male with a testicular mass, orchiectomy is the surgery that is a standard protocol. So orchiectomy was performed for this patient, and you can see a bivalve orchiectomy specimen over here. Most of the testicular parenchyma grossly appears normal. There is one small lesion over here. If you look closer at that, you will see the small lesion has a mucoid type cyst, and then there are some whitish areas and some fibrous and yellowish areas. So if you look at the microscopic sections of that cyst-like area, you can see that it's lined by this very bland appearing thin layer of ciliated respiratory epithelium. Right? And then the surrounding testicular parenchyma, the seminiferous tubules, they essentially look normal. So if you look closer, again, you can see clearly what I was mentioning as ciliated columnar epithelium with some secretions, which looks like almost like respiratory lining or tubal lining or something like that. And then again, the seminiferous tubules, I do not see any evidence of GCNIS, and some of them have clear evidence of spermatogenesis to full maturity. So if you look at other areas of the tumor, the more whitish appearing areas, we find there is clearly evidence of mature bone formation, and then there are adjacent areas that have a little bit of scarring or fibrous change. And then again, if you look at the interface, you do see some normal seminiferous tubules. So the differential diagnosis at this point is this is a benign teratoma, which is of prepubertal type, right? But we have to remember that this patient is 29 years old and is an adult and not prepubertal. And also there is histologic evidence in the testis itself that is undergoing spermatogenesis. So it cannot be prepubertal. So this is a very strange diagnosis here. And then of course we have a teratoma which is of postpubertal type. Now we know from our previous discussion that all postpubertal teratomas, whether they are mature or not, are malignant. And then the other possibility is maybe teratoma is just a component, and maybe this patient actually had a mixed germ cell tumor where the other components other than teratoma had undergone regression. So this is an uncommon phenomenon, but it's not very rare. We do see regression in many testicular germ cell tumors, right? Maybe this is what happened in this case. So to make a diagnosis of both of these, that is the post-pubertal type of teratoma, which is malignant, or a mixed germ cell tumor, so we need to see dysgenetic features that I was talking about before. So we need to see dysgenetic features in the adjacent testis, such as scarring or presence of atrophic tubules or presence of Sertoli-only tubules. And then we can confirm this by doing FISH tests for chromosome 12p overexpression, where the abnormality is isochromosome of the 12p. So what about this case? Did it have any of these dysgenetic features? So if you look closely at areas that were surrounding this mature bone, we initially saw some scarred areas, right? So there are some fibrotic areas around here. And adjacent to this, we can also see some tubules that are completely atrophic. And adjacent to that, we see some tubules that may be showing some features of partial atrophy. So again, in another area, which is away from the bone, you can see areas of tubular atrophy. Maybe maybe the thought process could have been the bone is causing a pressure effect, and the adjacent testis causing fibrosis and atrophy. But some features were also present away from those bony areas, which was similar. And again, same phenomenon here. You can see part of this respiratory lining here, the cyst, and then some features that look like it could possibly represent as far. But then that cannot be the only feature, right? You look again carefully for distinct features in the rest of the testis, and you do not find any evidence of GCNIS at all. And in fact, as I mentioned earlier, you find that there is complete maturation into spermatids and sperm in most of the tubules. And you can also confirm this by doing an OCT4 stain, which in this case clearly showed there was no evidence of GCNIS. OCT4 is, as you know, an excellent stain for picking up not only seminomas and embryonal carcinomas, but also the presence of GCNIS in the seminiferous tubules, and that was completely negative. And then we also did a FISH test because of the strange presentation of this case in a post-pubertal male patient. And the FISH test, as you can see, was completely normal. There is no overexpression of chromosome 12p. All the red signals equal the green signals, and this was a normal FISH test on the respiratory type epithelium. So the diagnosis in this case was a little bit perplexing because everything pointed to a benign teratoma. And we know benign teratomas preferentially occur in the prepubertal male, but this is a prepubertal type benign teratoma just occurring in a postpubertal testis. So that was the diagnosis here, but as I said, it's kind of a strange diagnosis. But that's not the end of the story. So this patient also had an abdominal CT. So this abdominal CT, which is basically they do this abdominal CT as staging workup for all comers of testicular tumor. This is part of the workup. And then they found this mass, as you can see in the retroperitoneum. It's quite large, about 9 centimeters. It's lying against the paravertebral muscles, prevertebral muscles. And then here in the coronal slice, you can see this large mass, which is heterogeneous in appearance, which is at the bifurcation of the aorta. So this mass was resected. And this is what you see in the resection specimen. Multiple cystic areas, and then you can see this yellowish, almost fat-like looking areas, and then you can see other fibrous components as well. So if you look closer, one of these slices actually showed this. And this, what is this? It's quite obvious. This is actually hair. So this looks like what you might see in a ovarian teratoma. Right, a benign teratoma in the ovary where you typically see hair. Okay, and the histology also showed similar features. Here, as we discussed earlier, we see some really well-formed teratomatous elements, partially squamatized respiratory type epithelium, underlying smooth muscle and underlying mucus glands, some pancreatic acinar-like tissue, again very organoid, and perhaps some neural tissue over here. And then again, you have some neuroectodermal type tissue with the pigmentation and maybe some choroid plexus-like tissue. And then almost an appendix-like element over here with colonic type epithelium and a nice double-layered smooth muscle wall, even with ganglion cells. So this is a perfect organoid formation. So there is no atypia, there is no mitotic activity, or there is no abnormal glandular elements in any of these. And then, of course, we also wanted to do a FISH just to confirm. And again, the FISH came back as normal. So this does not look like a postpubertal type teratoma again, but it's very, very odd. So a differential diagnosis at this point is, this is a primary teratoma unrelated to the testicular one, which is present in the retroperitoneum, and it is of prepubertal type. This is very unusual because the current concept, current thinking is primary retroperitoneal germ cell tumors do not exist. There is no definitive evidence in literature that this location, the retroperitoneum, unlike the mediastinum and the pineal gland, is a primary location for a germ cell tumor. All of these are considered as metastasis from the testis, right? So this cannot be a primary teratoma. So then the only option that we have left, this is a metastatic teratoma of the prepubertal type. So evidence for this is the patient already has a testicular primary, and in the specimen that was resected from the retroperitoneum, there was some evidence that indicated perhaps a lymphovascular invasion. So you can see a wall of a large vein here and a huge thrombus. And then if you look at one edge of the thrombus, this seemed to show some flakes of keratin, perhaps some part of the teratoma metastasized as an embolus, and this is all we are seeing over here. So the final diagnosis in this case was a metastatic benign teratoma, because we could never prove malignancy here, and every morphologic feature, cytogenetic feature, seemed to indicate that it's benign. And this is a prepubertal type teratoma, which is not only benign, but also metastatic in adults. So very, very unusual case. It's almost analogous to sometimes what we call as benign metastasizing leiomyomas, or sometimes we see giant cell tumors of the bone that metastasize to the lung, but they behave in an indolent fashion. So this could be something analogous to that. Very unusual case.
Was this the only case in the literature, or do you find any more cases like this?
We searched and could not find anything like this. This was even looked at by some top genitourinary pathologists, and none of them could really say how this even happened. So this is a case that is worth publishing. I've been meaning to do this for a long time, but it's just sitting there.
Very interesting. Very, very
Dr. Sita Lakshmi here, Vijay, Sandhya, and Padma.
Yes,
see, testicular teratomas we rarely come across here, isn't it? I'm surprised that they've seen so many cases.
exactly. Yes, ma'am. Yes,
yeah, because see, we very often see ovarian teratomas.
ovarian teratomas, yeah.
Yeah, but testicular teratomas are very, very rare here, Dr. Paari. I'm really surprised that we got so many cases for discussion. I don't know whether
like you're right. Most of the time when you get teratomas, they are always part of the mixed germ cell tumor, right? So you see mostly embryonal seminomas, and then you also see some component of teratoma. Pure teratomas without the other components is extraordinarily like it's an unusual phenomenon in any part of the world, unless you're talking about the pediatric age group.
Okay, thank you.
I don't think we have reported any pure teratoma of testis in a long time here.
That is what I'm saying. That's what I'm saying, because you know, from our experience, all ovarian teratomas are invariably benign, you know, like dermoid cyst and things like that. But testicular teratomas are always malignant, and as he said, it is usually part of cell tumors. So pure benign teratoma of the testis, I don't think I have seen in my 40 years of experience. That's why I was surprised when I listened to his talk. So anyway, thank you for enlightening us on this.
That's why I said it's very interesting to see that benign teratoma in testis and that too metastasizing in the retroperitoneum.
Yes. Extraordinary case.
Thank you for sharing this wonderful case.
Sure, you're welcome. So if there are no more questions on this case, we can go on to the next one. Okay, so this is case 3. This time we will discuss a tumor in the kidney. So this is a patient who's a 59-year-old male who presented to the clinic with hematuria, and CT scan actually showed a large left renal mass, and so he underwent a radical nephrectomy. So this is what the nephrectomy specimen shows. So you can clearly see here there is a very large infiltrative, heterogeneous looking solid mass that's occupying the mid and upper pole of the kidney. So microscopic sections from this tumor. So here you see that there is a highly aggressive appearing infiltrating tumor, which has some papillary or tubulo-papillary structures. And in closer appearance, you can see that in this particular field, there does not seem to be a huge lot of cytological atypia. In fact, they are all single layers, almost resembling what we see in PRCC type 1. In other areas, there was a very remarkable feature where you saw a lot of this inflammatory infiltrate, mostly neutrophils. And then the tumor actually was highly heterogeneous. So you can see that this area doesn't look anything like what we saw previously, because there is a lot of myxoid type change and maybe some spindling of the cells and also some tubular appearance. Right? And then in other areas, the tubular appearance was quite enhanced. So a lot of these tubules were obvious, and they were much larger. And then these really did become much, much larger, almost formed like cystic elements. So tubules and cysts over here. And then some more morphology. So there were areas in which the tumor formed these solid clusters and started showing some clear cells as well. So again, you can see in this area, solid clusters with a little bit of spindling and nets of clear cells. And then we also saw areas where the tumor was infiltrating into the sinus fat, where it was so poorly differentiated, essentially sheets of very anaplastic looking cells. And then in other areas, very poorly formed glandular structures that was infiltrating the stroma with a desmoplastic stromal reaction. So if we go back to the orientation or location of the tumor, you can see that in some areas the tumor was actually abutting against the pelvis or calyceal structures. And then here we can clearly see the sinus fat invasion. And this is an example of an area where the tumor shows perinephric fat extension as well, which is reaching the perinephric fat resection margin. And then it also had a lymphovascular invasion. So this is, as you can see, a morphologically very heterogeneous tumor. Many areas it looks high grade. But at this point, let's talk about some differential diagnosis based on all the morphologies we saw. So firstly, we saw areas like this, which could very well represent something that we might see in a papillary renal carcinoma. And then we also saw areas like this with this mucoid type change, spindle cells, and some tubules, which could represent something similar to a mucinous tubular spindle cell carcinoma. And then we also saw these cystic areas, these tubules. We know there is this entity called tubulocystic carcinoma, and also areas that form nests with clear cells. So you could potentially think of clear cell renal carcinoma, and especially one has to remember high-grade clear cell renal cell carcinomas can look like anything. And then finally, we saw the tumor abutting against the pelvicalyceal urothelium. So high-grade urothelial carcinomas can also take on this appearance. And once we have high-grade urothelial carcinomas, we should also include collecting duct and medullary carcinomas that may have this high-grade infiltrating glandular appearance with desmoplastic stroma. Finally, there is always this category called renal cell carcinoma, unclassified. So at this point, these are our differential diagnosis. And obviously, in a case like this, immunohistochemistry will help narrow down our differential. So first of all, the easy thing to rule out would be a urothelial carcinoma. So well-known urothelial markers, high molecular weight cytokeratin and GATA3. The high HMWCK is only focally positive and GATA3 is completely negative, right? And PAX8 is diffusely and strongly positive. So this essentially, for us, takes out urothelial carcinoma from the differential. And also, we can essentially rule out mucinous tubular spindle cell carcinoma and tubulocystic carcinoma. These were just put in there for completion purposes because we know that the areas that look like these two entities were only focal, and most of the other areas of the cancer looked very, very different than what you would see in these two entities. These two entities usually are homogeneous throughout the tumor. So these can also go out. So then what about the remaining entities in the differential? So the main entity as I mentioned, it's a clear cell renal carcinoma, which can often have a very varied morphological appearance, especially when it's high grade. So it's always important that you rule that out. So as we discussed in the lecture, CA9 or carbonic anhydrase 9 is an excellent marker for clear cell renal cell carcinoma because it is one of the proteins that is overexpressed due to the VHL gene mutation. So essentially all clear cell renal cell carcinoma should be positive for CA9. And this particular tumor, we see CA9 is positive over here, and high power, we can see many of the cells in here positive. But in some areas, we even see positivity for CA9 in this cup-like pattern that I was talking about earlier in clear cell papillary renal cell carcinoma. So should we even include this in the differential? The answer would be obviously no, because as we discussed, the clear cell papillary renal cell carcinoma should have this morphologic appearance at least somewhere in the tumor, which we did not see. And then CA9 in clear cell papillary renal cell carcinoma should be diffusely strongly positive throughout the tumor. In this tumor, if you go back and look carefully, CA9 is only positive in a patchy fashion, right? And that positivity is around the area of necrosis that we see over here. And CA9 being a marker of hypoxia as well is going to be positive in areas of any tumor that show hypoxic changes, right? So this is not surprising, and this essentially this pattern of staining where the rest of the tumor is negative rules out both these entities. So the clear cell renal cell carcinoma is also out because this also should be diffusely strongly positive for CA9. So then we have only very few entities remaining in our differential diagnosis. So what about papillary renal cell carcinoma? We can see high-grade papillary renal cell carcinoma sometimes. So PRCC, as we know, are usually positive for CK7, and this tumor was diffusely positive, and racemase was also diffusely positive, as we see in papillary renal cell carcinoma. However, these two stains basically ruled out papillary renal cell carcinoma and nailed down our diagnosis. So this stain is OCT4, and the other stain is INI1, as many of you must have already thought of, because what you're seeing here is a positivity by loss of expression. You can see the tumor cells have lost expression of INI1, and you have very nice internal control, the stromal cells and inflammatory cells that are positive. So this is a renal cell carcinoma that is positive for OCT4 and has lost INI1. The only diagnosis here is the medullary carcinoma. Right, so let's go back and look at our morphologic images now. So medullary carcinoma, often we know, has extensive neutrophilic infiltrate, and we did see that. And then medullary carcinoma, as we know, forms poorly formed glandular elements. Sometimes it can have even mucin-like secretion, and typically it has a desmoplastic stroma, which we rarely see in renal carcinoma. So that was there. And this thing, which looked like a mucinous stroma, is again actually desmoplastic change, which is slightly different from the stroma that we see here. And the other thing is medullary carcinoma, you always look for areas of hemorrhage because you know what to look for over there. So if you look closely at these areas of hemorrhage, you can notice that many of these cells are actually sickle-shaped. So as we know, medullary carcinoma usually occurs in young Afro-American males or Africans, and it occurs in the second to third decade. This patient is very unusual, even though he was Afro-American male. This was an older patient, but we did find out that this patient had sickle cell trait diagnosed at a younger age. And as we know, medullary carcinoma acquire OCT4 immunostain and they lose INI1. So this is a case of medullary carcinoma, which is a highly aggressive carcinoma of the kidney. Any questions on this case?
I don't think there are any questions.
Right, then maybe we should move on to the last case. It's case 4. And this one is from the bladder. So again, we have a younger male who presented with history of hematuria. He also had other medical issues. He had a history of Fanconi anemia, and he also had bone marrow transplantation for that, and that induced cystitis. So they were scoping him for some time, and this time they saw bladder lesions on the cystoscopy, for which they performed transurethral resection. So in this transurethral resection specimen, this large fragment, we see a polypoid structure, which has a lot of these unusual cystic elements. This is a very unusual presentation for a bladder tumor. And if we look closely, we see many of these cystic elements are lined by these sort of hyperchromatic cells, which seem to have some hobnailed nuclear appearance here, and they seem to have some secretions. And then in other areas, these cystic elements seem to kind of conglomerate into these microcystic little tubules. And now the lining cells became a little bit more flattened, and they look almost like endothelial cells or blood vessels in here. So at this point, just with these 3 or 4 morphologic images, the things that you might want to consider in the differential diagnosis is a very unusual case of cystitis cystica. And of course, you might want to consider a possibility of nephrogenic metaplasia or nephrogenic adenoma. And then if it's malignant, you want to think of this unusual variant of urothelial carcinoma called microcystic variant. And maybe it is just an adenocarcinoma with an unusual morphology. So those are the things that you might have in mind. So let's go back and take a look at some more sections from the tumor. So again, here you see a lot of these microcystic elements that we saw previously, but now it seems to be getting a lot more complex, and we seem to see some very atypical pleomorphic looking nuclei in here. And then in other areas, again we see the increase in complexity, almost forming a little bit of a solid structures. So it no longer appears like any kind of a benign entity. And this is further enhanced, this thought process is further enhanced when we see areas like that, like this, where it's clearly looking like some malignancy, which is juxtaposed to these areas that we saw initially with the hobnail cells, and then with these microcystic structures. And if you go further, you will see that this has a very back-to-back cribriform pattern of complex glands with mitotic activity and apoptotic figures that look like a high-grade cancer. And in this final image, you also see that many of these gland-like back-to-back elements have clear cells and pale eosinophilic cytoplasm in some places. It's clearly a high-grade malignancy now. There is no doubt about it. You also see some very atypical mitotic figures. And you can also see areas where the tumor is clearly invading into the muscularis propria. So at this point, it's kind of silly to consider cystitis cystica in the differential, so we just take it out. And then we also know that this is not nephrogenic metaplasia because this is malignant. And then we are left with 2 diagnoses. So could this be some sort of a divergent urothelial carcinoma? Now we know that urothelium as a histologic element is very plastic, and it can show a lot of divergent differentiation: squamous carcinoma, adenocarcinoma, small cell, sarcomatite. There can be a lot of things that happen. So maybe this is some kind of unusual divergent urothelial carcinoma. And then you also have to consider the probability of a pure adenocarcinoma, which could be either primary or which could be possibly metastatic from another location. Right? So let's do a simple stain here. So this is a stain for Paxate, right? And you can see that Paxate is diffusely strongly positive in pretty much all the tumor cells. And GATA3, which is a very good urothelial marker, is almost completely negative, only few cells scattered here and there. So at this point, divergent urothelial carcinoma is gone because the tumor is Paxate positive and negative for GATA3. That would be an unusual profile for a urothelial carcinoma, even one with divergent differentiation. So we are left with that diagnosis of adenocarcinoma now. And so we have 2 differentials here, whether it's metastatic or primary. So this patient is a 37-something-year-old patient, it would be unusual to get metastasis at this age, especially when you don't have any history of a primary tumor elsewhere in the body. So we are finally left with a diagnosis of primary adenocarcinoma of the bladder that's not arising from the urothelium. So this actually is a clear cell adenocarcinoma of the bladder of the Mullerian type, the type of clear cell carcinoma that you often see in the ovary and sometimes in the uterus. So this cancer, obviously, when it occurs in the bladder, even in the bladder, it has a female predilection, and it has very similar morphologic features to what we see in the female genital tract clear cell adenocarcinoma. And typically, as is found in these tumors, these will be positive for Prostate and negative for CATA3, as we saw in this particular case. And it might also resemble nephrogenic adenoma in many areas. So the histogenesis, the theory is that most of these arise actually de novo from the urothelium itself, or in case of female patients, they may be associated with foci of endometriosis that give rise to these clear cell adenocarcinoma. This case, though, is somewhat unusual because here is the cystectomy specimen, and you can see the tumor over here, normal urothelium. So let's focus on these two areas. So this area basically shows the cyst-like elements that we saw, right, and the small gland-like elements, and the other one basically shows these papillary structures. So if you look closely at these areas, the cyst-like elements are lined by relatively bland cells that kind of look like endothelium, and there are areas where it also shows some hobnailing. And the same with the papillary-like areas, some cyst-like structures, some small papillary finger-like structures, and some hobnailing. So this appearance, if I just see this in isolation, this is typical for nephrogenic adenoma or nephrogenic metaplasia. And if you go further in this case, you can see again areas that look like nephrogenic adenoma in clear transition with, so you can see, in fact, part of this gland looks like it's lined by benign cells, and part of this gland looks like it's lined by malignant cells. And then we start seeing obvious malignancy very adjacent to these elements. So it's possible that this is a clear cell adenocarcinoma of the bladder Mullerian type, which is actually originating from a pre-existing nephrogenic adenoma. Right. That's the end of the final case. Thank you very much for your attention. Are there any questions on this one?
Thank you. Hatak has a question. Was this napsin positive as well?
Which one? Oh, yes, nephrogenic adenomas. Yeah, though those can be, I don't think we did napsin in this case. No, we did not. Yeah.
Dr. Meera has complimented again. Thanks, sir, for the wonderful session.
You're welcome.
The 4 cases were so unusual and so rare, and I don't think I have seen a medullary carcinoma in the kidney. And of course, definitely not a teratoma in the testis itself, to see a metastatic benign teratoma in the retroperitoneum. And neuroendocrine, of course, we don't apply the markers, because even when we get poorly differentiated, I don't think I thought of doing a synaptophysin or chromogranin. And maybe if I'd seen a hypergranulated cells, we would have thought, but then poorly differentiated. Maybe now we'll start including these markers as a routine whenever we see poorly differentiated areas. And the last one, of course, again, a very, very rare case. So interesting. And I mean, we should be really, really thankful to you, because it's almost beyond midnight for you. I think it's 2 a.m. in the morning, and you're still so active and really amazing.
Yeah.
1:30 a.m.
No.
It's so amazing to see a person like this who's so interested in teaching and sharing, disseminating and sharing your information, whatever you have. And this is what I think we do celebrate International Pathology Day, where we can globalize our knowledge. And probably for us, people sitting in India, it is so useful listening to this. So at least we know what are we missing and what else we can add, which are feasible enough to do at least. That way, it was a very, very useful lecture and case discussion. Thank you so much, Dr. Paari. I mean, I really didn't expect that it would go up till 12, and you're so awake and so active. Really, really. I mean, there are no words to describe for this kind of interest in disseminating knowledge. Thank you. Thank you so much.
Thank you. Thank you very much. I have to say it's been a great pleasure. The pleasure is all mine. In fact, it is so good. I mean, this pandemic has been so terrible, but in many ways it has, made the Zoom presentations it's brought that into the mainstream, right? Because of that, so it's easy for us to connect with our colleagues across the world in different time zones and share this type of information and knowledge with everyone. So I think it's really fantastic. And I have to thank you for the opportunity to talk to all of you and then have this very interesting and stimulating discussion, actually.
This was a wonderful CME, and what to talk about Paari. I mean, he was an outstanding postgraduate and very, very hardworking. And it's no wonder that he's gone so high in his career. And I think everyone is very fortunate today to have listened to such a vivid presentation by Dr. Paari. Thank you so much, Paari.
A wonderful person to speak on today, actually, and that in a very short notice. Thank you all the participants, and thank you all my teachers, my mentors who are all here, and my colleagues and my dear students. And thanks a lot to Dr. Paari. I think we will keep disturbing you henceforth. Now that we know you're active even at 2 a.m. in the morning, I think next will be bone pathology. We'll be waiting for that, I think.
Yeah, we'll keep calling you, Dr. Paari. Please be ready. Every year, at least one session, we'll keep calling you. So anytime, please be ready with your cases.
Okay. Yeah, next time maybe we can do soft tissue bone conference because I practice that also.
I saw your papers in that. That's why I thought I should catch hold of that as well.
All right. Bye. Have a good evening.